Today is a slide seminar on approach to spleen pathology. Our presenter are Dr. Anita Borges and Dr. Praveen Mahajan. Anita Borges ma'am is working as a consultant pathologist at Center for the Oncopathology, Tata Trust, Mumbai. And Dr. Praveen Mahajan is working as a consultant pathologist at S.L. Raheja Hospital, Mahim, Mumbai. The chairperson for today's seminar is Dr. Sumit Gujral sir, who is working as a professor of Department of Pathology, Tata Memorial Hospital, Mumbai. Today's participants are Dr. Ravi, Dr. Fode, Dr. Arun, Dr. Madina, and Dr. Sambhavi. Introduce Dr. Ravi yourself.
I'm from hygienist, Dr. Aisha and Dr. Fode for the idea.
Dr. Fode.
Who else is going to introduce themselves? Dr. Arun?
Good evening to all the faculty and my colleagues and my juniors. My name is Dr. Arun. I'm a second year resident from Rajiv Gandhi Institute of Medical Sciences, Adilabad.
Okay, Dr. Fodeki?
Good afternoon from this part of the world. My name is Dr. Fodeke, and I'm happy to be part of this conference.
Welcome, Dr. Fodeki. Have you been on the program before?
Well, yes, I have, but I didn't finish.
Is your name Israel?
Yes, I'm also Israel.
Then I remember you as Israel. Very good.
Oh, that's fantastic.
No, it's an easier name to remember than Fodeki. Dr. Shambhavi, would you like to say introduce yourself?
Good evening to all. I'm from KMC Manipal. I'm a first year GR.
Okay, good. And Dr. Madina?
Good evening, everyone. My name is Dr. Madina. I'm happy to introduce myself to everyone, and I'm from Tashkent, Uzbekistan. I'm from Tashkent Medical Academy, and I'm very honored to be the part of today's session.
Well, welcome everyone, all of you, to this program. Urvi, you want to continue?
Yes. Moderator for the today's seminar are Dr. Bushra Siddiqui, working as an assistant professor, Department of Pathology at Jawaharlal Nehru Medical College, AMU Aligarh, and myself, Dr. Urvi Parikh, working as an assistant professor at Department of Pathology, BJ Medical College, Ahmedabad. There are some reminders. If there is a connection interruption, low sound or no sound, video freezing or video lag, kindly leave the meeting and rejoin. If the same problem persists, check your internet connection. Please answer the poll question in the chat box, and please do not send the request for the annotation in between the presentations. There are some disclaimers. Our upcoming talks, they are Journal Club on How to Read Pathology paper by Dr. Sanjay Pai, who is working as a consultant pathologist and head of pathology at Manipal Hospital, Bangalore, India. That seminar is on 8th June. And on 13th June, our next talk, that is Ethics, Research and Publications, Copyright and Plagiarism Issues by Dr. Sanjay Pai. Let's start.
All right. Thank you so much, Urvi. And I think if you can stop sharing, then I'll share my PowerPoint. Okay, last time when we were talking to you, all of you, I said that those who were at least the 5 students who were 1 minute, let me get this full screen. Okay, who were going to be here at this slide seminar. Of course, today it's not just myself and Praveen, but there's also Dr. Sumit Gujral, who's not just going to be the chairperson. He's also going to share some of his slides, because we've cobbled this thing together as a result of somebody who probably would have done a much better job. That's Dr. Geeta Menon, who was unable to do this talk. All right, so let's start. But I did ask those who were the students, all Arun and Ravi, and Apeksha is not with us today, but Shambhavi and Madina, and of course now Israel, to do a little bit of reading on the spleen, because you know that the spleen, I don't know why I'm not, okay, has always been a very mysterious organ. There's like a veil that is on the spleen. You think about it, how much did you learn about the spleen in your anatomy and physiology? Of course, we knew that there was a spleen, and we knew the spleen really as one of those organs that enlarges, and it enlarges when there is cirrhosis of the liver, when there happen to be, there's malaria or something else. But honestly, we didn't know too much about the spleen. At least I didn't know too much of the spleen. So what we are trying to do today is to unveil, the spleen, and see whether what has been acquired, what kind of information and knowledge and understanding basically has been acquired by the spleen. And of course, all of you are postgraduate students, and somewhere or the other, you will encounter the spleen. Okay, so it's whether it is, at an autopsy when you have to examine the spleen, or sometimes when at a splenectomy, or nowadays more and more commonly, we're getting core biopsies of the spleen. Indirectly, you may come across the pathology in the spleen, not because they take out the spleen or because they biopsy it, but because the pathology in the spleen is reflected elsewhere in the body. So all of this, I think, we will try and give you an understanding of what goes on in the with respect to the spleen. Okay. Hey, what happened? There's somebody speaking. If we can possibly. All right. So that's what we're going to do. Now let's just tell you a little bit about the spleen, because the spleen is an interesting organ in the sense that we use the spleen, or we refer to the spleen in everyday language, at least if you're an English speaker, and perhaps also if you you speak any other Indian language and you're familiar with Ayurveda, then you will have heard of the spleen. It's known as a pliha in Ayurvedic texts, and you know that there are three humors in Ayurveda, and one of them is pitta, and the spleen is involved in generating and in some way in how this pitta causes disease and is also related to health in your own body. And Ayurveda had got it right, because Ayurveda said that the spleen was involved in combating infections, and we know that that is true today. But this word spleen, which we use, and a lot of the Western world uses the word spleen, comes from the Greek word. Okay. Now, any of you, let me start with Arun. Arun, do you know any Greek alphabets or words?
Sigma or pi, alpha, beta, delta.
No, sigma and phi. Very good. Okay. And does Ravi know any Greek alphabets? Ravi, you know any alphabets? Tell me. Yeah, do you know any Greek alphabets, Ravi? Now,
Yes.
Arun said that he knew sigma and phi. Do you?
उसके बाद म्यू है मैम ये
Mu, acha, you heard of mu? Yes, very good. What about Shambhavi? Do you know any Greek alphabets?
Yes, ma'am.
Tell me, what Greek alphabets do you know? Can you think of any Greek alphabet that you know? All right, I'll give you time to think. Israel, you know any Greek alphabets? No? Israel, can you hear me? Israel, has he gone? He's disappeared. Anyway, Madina, do you know any Greek alphabets?
Yeah, I know a little bit. I know.
Can you
Kappa,
speak closer? Can you come closer to the mic?
Hello. Yes. Am I audible?
Yes, you're audible. Tell me.
So I know Omicron. I mean, depending on this, it's like Omicron. I think it's B and.
No, do you know? Have you heard of any Greek alphabets?
Yeah, I've heard. I know Kappa, Lambda. Yeah, like
There you are. So we all know Greek alphabets because we have alpha, we have beta, we have kappa, we have lambda. So can anybody recognize any of these that you see here in this Greek letters over here?
Yes, ma'am.
Yes.
First is sigma, second is pi, third is lambda, fourth is
Fourth is lambda? No.
no, third is lambda, ma'am.
Yes.
How do
Yes.
you get that?
Fourth is new, fifth one like I have no idea.
No. And the fourth is not new. Fourth
actually.
is eta.
Okay.
Okay. See, it is spelling out the word that is next to it. No, split. And this just tells you that our English, a lot of our English characters that we know and are familiar with, are their phonetics comes from a lot of the Greek words. Okay. And that thing that looks like a V is actually new. Now let's quickly see this. You see this? You know that if you look carefully here, sigma, you were absolutely right. Who was that? Arun, right?
Yes,
That is sigma. That's the small sigma. If you want a big sigma, it's like a big E. Okay, when you are trying to summate something, you use sigma, right? All of you, have you heard of Six Sigma? Anyway, if you haven't heard of it, if you're doing any quality work, people have heard of Six Sigma. All right, the next one was pi. We know pi r squared. Yes, then you correctly identified lambda because we use that all the time. Then this one is eta. Okay, it doesn't actually stand for an E, but it is often pronounced as E because you also have epsilon. And this one is nu. So the whole thing spells splen, or in Greek. Okay, but all of you were right. You made the attempt. You see that? We use this all the time: alpha, beta, gamma, delta, mu, and chi. You know, we do the chi-square test. Yeah. So we are constantly using Greek alphabets. But do you know what? Have you heard of omega? What's omega?
The resistance, the symbol for resistance.
The symbol for resistance. Yes, it is a symbol for resistance. It is just like we say from A to Z. Yeah, you say in the Greeks would say from alpha to omega. Yes, it's the last character in the Greek alphabet. But there are people who advertise omega. No, what is omega?
Watches, ma'am.
Watches. Yes, you have the omega watch, and if you see the symbol for the omega watch, it is exactly like that. And what is iota? Has anybody heard of iota? We use it in English all the time. Iota means a very, very small amount, and that's why we say there is not even an iota of common sense in what you are saying. Means a very tiny amount. So when people say, "Do you speak Greek or can you read Greek?" Of course you can, because we are familiar with many of the Greek letters of the Greek alphabet. Okay, right. So now we know that the word spleen comes from the Greek. It is the way that we use it. And you know that the Greeks believed that the spleen was responsible for making black bile. And now you know what is black is melon. That's why we have melanocytes, etc. That's pigment. That's black. And cholia is bile. Right? That's why we talk about cholecystectomy. The gallbladder is the cholecyst, or that's why we call it cholecystectomy. So it contains bile, and therefore people believe that if you had too much black bile, you were depressed. And this word has come into the English language. We call it melancholia or melancholy. So somebody who is very depressed or sad a lot of the time, that kind of personality is called, somebody has a melancholic personality. And the word comes from this, black and bile. But over the years, the spleen has also been said to be the source of anger. And therefore, in English, we often say to vent one's spleen. That means to get our anger out. And so it means getting very angry or to complain bitterly or to air one's grievances. I just gave you this, as an introduction to the spleen. I don't think you need to remember this, and nobody's going to ask you this in the exam. But it was interesting. I went to see what Wikipedia says about the spleen, and I was so disappointed. You know what Wikipedia says about the spleen? In more than one place it says, of course, it tells you that the spleen is an organ found only in vertebrates. Okay, and almost all vertebrates have spleens. Before vertebrates, there was no spleen. It is similar in structure to a large lymph node, and it acts primarily as a blood filter. Again, it says that the spleen is analogous to a large lymph node, and I think it is doing an injustice to the spleen, because the spleen is not just a large lymph node. It has many more functions, and it does much more in terms of hematological physiology than any lymph node ever does. Okay, and then the last line in Wikipedia says, in humans, the spleen is purple in color and is in the left upper outer quadrant of the abdomen. So I thought, everybody thinks that what's on the net, and particularly in Wikipedia, must be so true. And let me tell you that you would be very let down by Wikipedia if you believe that what is in Wikipedia is the gospel truth. It is not. We need to go to several sources to find our information. Okay. All right. So now we will take the case. And who would like to take this first case? Is Israel there, or has he disappeared?
Yes, ma'am.
Are you there, Israel? Is Israel there? Doesn't seem to be there. All right. So let's start with somebody else. Okay. Shambhavi, would you like to take this case?
Yes, ma'am.
Oh, Israel, you're there. Okay, but I can't hear you. Is there a lag? Okay, come on, Israel, take this case. Read.
Okay. Can you hear me?
Yes, we can hear you now.
Okay, so this is case 22W5694. The
Yes.
case of a 29-year-old who presented with pain in the abdomen. CECT shows a well-defined 6 cm solid mass indenting in jejunal loop. The intra-op findings shows a knotted mass of bowel loops was found in the left iliac fossa, and the gross examination findings revealed a dark reddish-brown mass in the mesentery.
Okay, good. And here's the gross appearance, and you can see that the forceps is has the mass has been cut, and there is a cut surface that is being exposed where the forceps is. So you see this; it is extremely dark, almost black in consistency. Come on, Israel, let's describe this. This is the cut surface. Yes.
This is a micrograph of the histoarchitecture of the splenic tissue, showing an eosinophilic areas and these basophilic spots, which are the red pulp and. Can you hear me?
Yes, I can hear you, Israel.
Okay, yes, the eosinophilic field and these basophilic spots, and on this magnification, that's what we can see, and surrounding capsule, a thickened capsular.
Yes, Israel, you said it was a spleen. Why did you say it was a spleen? Because it's been in the spleen seminar, or why do you say that it is the spleen? Why isn't it a lymph node? It is the size of a largish lymph node. So why isn't it a lymph node, Israel?
Well, the lymph node has a capsule as well, the cortex, the paracortical zones, and the medullary zone. The arrangement of the follicles here, well, it's unlike what we see in the lymph node.
So are you saying, Israel, that if you took a slice of a lymph node, you would find the follicles only at the periphery and not in the center? Is that what you're saying?
Mostly at the periphery.
Mostly at the periphery. Let me ask the others. Okay, Israel, you did a good job. You said it was the spleen, but I'm trying to find out why it is the spleen. All right, Madina. Israel said it is the spleen. Do you agree it is the spleen?
It looks like spleen to me, but I have other argument why I think so. Because for me, it looks like it's like divided into red pulp and white pulp rather than cortex, paracortex, and medullary compared to lymph nodes.
So you see a red pulp and a white pulp, okay?
So I can definitely say that there is kind of central arterioles which is surrounded by white pulp. Meanwhile, there's like other areas which is like red pulp, I think, and there is thickened capsule. And I don't think that it's lymph node because I don't see these zones. And so it goes, and I can see some trabecules, I think, which are coming from the capsule.
Okay. So now, so Madina has identified something very interesting. Madina, you know how to do annotation? To ask for annotation?
I think
we practiced it the other day, right? So you know that little squiggle on the right, where you have to click
in a proper way. Let me try. Yeah, so I sent the request for a link.
I've approved it. So now you've got a little pen that has popped up. So now
Yeah.
you said something about a trabeculum. Yes?
Yes.
Yes. So would you like to show everybody where that trabeculum is?
Yeah. So for me, it looks like this is like the capsule, and I can see these little trabecules
Yes,
here.
and you said that, yeah, that's the capsule, and you're absolutely right. So here is the what Madina has drawn. That's the capsule. Yes, and I'm just paralleling up what she has drawn. And then she went in, and you see this pink portion. It's like something that's come from the capsule. Now that everybody has seen it, I'm going to remove this the annotation, and now everybody can see that there is a trabeculum that has gone down from the capsule into the splenic parenchyma, and this is the spleen. It is the spleen because we have seen a lot of lymph nodes, okay, and all of you should have seen a lot of lymph nodes. We hardly ever see such a thick collagenized capsule, unless the lymph node is exceedingly fibrotic from some disease or the other. And the lymph node doesn't have trabeculae that go down into the lymph node parenchyma. Yes, it has sinuses, and yes, it does have some connective tissue that goes down, but that connective tissue does not have the same consistency and thickness as that of the capsule of the organ, which is the spleen. And what you see here is both a red, very congested areas, and you see these things which we often refer to as Malpighian bodies. I think that who is this who's talking? Because it's just try not to speak while I'm speaking, unless you have a question to ask, in which case, just put it in the chat box or raise a hand or something. Okay. So yes, this is the spleen. It is one big spleen, and it seems to have some nodular areas outside, which we may refer to as splenunculi. All right, good. Israel, now do you see this at higher power? And I think at higher power, you can see this very thick capsule, and it's got, I think, yes, Israel. And your impression that you never see follicles or B cell areas inside the lymph node away from the periphery is not right, Israel. So the next time you go and look at a lymph node, look at it carefully, and you'll see that it depends on whether a lymph node is reacting, also on how it is bisected. Because if you bisect it very carefully through the hilum, that's the kind of picture that that is very ideal, that everybody says there is a cortex and there is a medulla. You hardly ever really see that. Okay, yes, you see lymphoid follicles, you'd see a paracortical T zone, but you don't normally see it as you would expect to see in the kidney or something, where a well demarcated cortex, a well demarcated medulla, etc. Okay, now Israel, you have anything to add over here? No, except now you can see the red pulp. Can you not, Israel?
Yes, I can see that.
Good. Yes, you can see the red pulp now. And now you see
Yes,
a really high power.
the white pulp. Yes.
Now you tell me, what are you seeing here, Israel?
The white pulp.
Yeah, you can see the
Okay,
white
so
pulp.
here I can see part of the capsule and the field of red pulp, and within it, surrounding the white pulp, and an extension of the capsule, like a septa, into the substance of the.
So you see the septi, and I take it that these are the septi, and
Yes.
you are right. You said that this is the red pulp, the white pulp, and the rest of it is the red pulp. But tell me something. Is there anything peculiar about this peculiar meaning that is different from what you see in a lymph node in the white pulp? Because after all, it's a lymphoid part of it, right? So is there anything peculiar about this, Israel? Or is it just like, what you see in a lymph node?
Not likely. We don't know. Not really. We don't see this kind of. We don't see this.
So what is
The white
different?
pulp in the lymph node. The white pulp in the lymph node is what the follicles are. The white pulp in the spleen is what the follicles are in the lymph node, and the red pulp, well, they are the rest of the. We don't really have a red
Now
pulp.
let us talk about the white pulp. And you can see my cursor. This
Okay, here we can see the.
Now tell me, just describe
You can
that,
see-
because this is what
Okay, so-
we call the Malpighian corpuscle in the spleen, right? And that's what gives you this little white dot-like gross appearance when you bisect the spleen, or you have a cut surface of the spleen. So now tell me, just describe what you're seeing over here, Israel.
So we are seeing the white pulp, which has a center of a deeply basophilic center and a rim of
Okay.
light, not as deep as the center zone, which is in
so
contrast.
the lymphocytes at the center, which you have described, are very dense and closely packed, and you have a very blue kind of area, and then you have a paler, less densely packed
Rim,
lymphocytes at the periphery. Okay, but what's right in the center, almost like the bull's eye?
The blood vessel.
What do you see, Israel? Here, what is this? You see something like a bull's eye right in the center. Does it?
Yes.
Yeah. What is it, Israel? All right. Will Shambhavi help Israel? What
Yes,
is
ma'am.
that?
Ma'am,
Just,
that's an
not just
arteriole
a-
which
okay.
is lined by
That is an arteriole. Yes, that is the essential difference between what you are seeing in a normal lymph node and a normal spleen. You see follicles in a normal lymph node. You see follicles. This is for all practical purpose of follicle. Because what do we use the word follicle for? Do you know what what the word follicle actually means? Yes, Arun. Do you know what the word follicle means?
Follicle means it's arranged in like a flower like or
No, a follicle is not arranged like a flower. That's a fleur or a floret or something. No. So what is a follicle, Ravi? Are you there, Ravi?
Yes, ma'am.
Yes. So tell me, how do you define a follicle? Because you have follicles in the node, you have follicles in the ovary, and you have follicles in the thyroid, right?
Yes,
So what
ma'am.
is a follicle? It can't be what Arun said, that it looks like a flower. So what is a follicle? How do we define a follicle?
Follicle means,
So why is the ovarian follicle called a follicle? Why is this a follicle? Why is the thyroid?
small secretory,
What is a
a small
follicle?
secretory, a small secretory.
Small secretory thing. So you think
Yes,
that in the lymph node the follicles are secreting?
No, ma'am. Yeah,
No, madam. So it cannot have anything to do with secretions, right? Now, Shambhavi,
ma'am, maybe because of the germinal centers.
because of the germinal center. You think there's a germinal center in the ovary, and there's one germinal center in the thyroid that we call it a thyroid follicle. Yeah? No, it can't be, right? But we use the word thyroid follicle, ovarian follicle. This is a follicle. It's called Malpighian corpuscle, but it's essentially a follicular structure.
usually,
Okay?
ma'am, cells are arranged around something in
Around
central manner.
structure. Really? You think that's why it's called
Because it's circular.
circular? Now you've come closer to the thing. Madina, why? What is a follicle? Why
Circular
do
arrangement.
these three things follicles? Thyroid, ovary, this.
Yeah, I think it's like small cavity which contains something. Like for
Sorry,
instance,
Madina, I can't hear you.
I think it's small cavity that contains
Small
something.
cavity. No, I don't think that the lymph node follicle has a cavity. No, it doesn't. Just look at its shape and think of its shape in three
Ma'am,
dimensions.
because of the round
A
structure.
follicle, yeah, this in 2 dimensions it is round. In 3 dimensions it would be what would you say?
Rounded.
Rounded? No, there is a 3-dimension.
Ma'am,
Yes.
wheels are fruit type structure.
No, it is a sphere. Come on, where's your physics and geometry gone? If you see something in 2 dimensions that is a circle, but this has 3 dimensions, you would call it a sphere. So a follicle is a spherical structure. Now you agree that that in 3 dimensions this would be a spherical structure? Yes or no?
Yes, ma'am.
Yes.
Yeah.
Yeah, Israel, is this a spherical structure in 3 dimensions? Yes, it is. And the
Yeah, it is
ovarian
a spherical
follicle
structure.
the ovarian follicle is also a spherical structure in 3 dimensions, and so also would be the thyroid follicle. Do you all agree or don't?
Yes, ma'am.
Yes, ma'am. All right. So now we have a follicle, but in the center, as I think it was Shambhavi who said that there is a vessel, there is an arteriole that is sitting right in the center. Okay, and this is a periarteriolar
Lymphoid.
sheath. Okay, lymphoid sheath. So what do we often call it? Or you see it written in the textbooks? Periarteriolar
Yes.
lymphoid sheath. So what? It's called pals. No, that's the word that is often used. Okay, so there is it's actually the artery, and we will see the structure of this, but that is what this particular thing is. Okay, now let's go to the next thing, and you can see this at higher power, and you can see that the arteriole, which is here at the periphery, has pierced this particular structure. It's not pierced; it actually the lymphocytes are around the arterioles. Okay, it's a characteristic feature of the spleen. Okay, next. Oh, why isn't this thing moving? Okay, let's all right. Now, what is this part of the spleen, Israel? Are you there, Israel? Or Israel has disappeared? Okay, Shambhavi, tell me.
And this is the red pulp.
This is the red pulp, yes. And you see beautifully over here that there are these dilated vascular structures, and these vascular structures do not have any kind of muscular wall. Do they? No, they don't. This is not like an arteriole. It is not like a vein. It's not like an artery. It's a sinusoid. Okay, so these are sinusoids, and the sinusoids are defined by the fact that they don't have any kind of muscle or even an adventitia in the wall, and there are spaces or gaps that through which stuff can go in and out of this. It can be cells or it can be fluid in and out of these sinusoids. There are many structures that have sinusoids. We have sinusoids in the lymph node, but those are lymph sinusoids. These are vascular sinusoids, and they have very plump looking vessels. Endothelial cells. These endothelial cells, if you notice, are not fat. then you can actually see the nuclei of these endothelial cells, which you hardly ever notice in many other sinusoids where the endothelial cells are flat. And of course, you've got the trabeculum here, and in this trabeculum, you have the splenic vein, and artery will come from the capsule into this red pulp. Okay, good. Now, I think people are asking for annotation because they're by mistake pressing that little squiggle that is at the periphery. Okay, this is an eccentrically placed arteriole, which is a very thick wall, and this is the lymphoid cuff that has been cut, tangentially, and that's why the arteriole is not sitting in the middle of this lymphoid tissue. Okay, now there's the red pulp again. Yes, you agree, Israel. There is a red pulp. It is very congested, and this is right below the sinusoid of the capsule of the spleen. So more pictures of the red pulp. So now, would you like to tell me, Israel, what is this condition? You don't require to think. No, it's very obvious. So what is this condition, Israel?
It's a normal spleen.
What is it?
A normal spleen.
It is
a normal spleen.
It is an additional spleen. Is that what you're saying? Because I can't hear you too clearly. But anyway, you know the observations. What is the most the principal cell of this lesion, Israel? It's the lymphocyte, right? What other features did we notice? And we have described all these features, okay? And you have this nodular, congested, and thickly encapsulated lesion. And you have these collagenous trabeculae or septi, if you wish to call them. And then you had lymphoid nodules surrounding the arterioles. And here is this lymphoid nodule that you see over here. And there were two zones that we noticed in this lymphoid nodule, an inner denser zone and an outer lighter zone. And then you have this extensive ramifying network of vascular sinusoids associated with lymphoid cells. There are lymphoid cells that are in this right. So now we have to do a little bit of an analysis. Okay, so Israel, now will you pick the most crucial decision on this decision-making tree? What is your most crucial decision? Is it congenital or acquired, physiological or pathological, neoplastic, non-neoplastic? Which will you pick, Israel?
So it's unlikely that it could be congenital considering the age of the patient. So it's most likely going to be acquired.
It's likely to be acquired, according to Israel. Okay. Anybody else?
Yes, no.
Congenital. All right. Ravi, what do you think?
Ma'am, accessory.
Sorry?
Accessory spleen.
Accessory spleen, yes. But do you think it's congenital or acquired? What? Which of these?
I think it's
Congenital. But what will you tell Israel? Israel said that this is an adult. So how can it be congenital? So what will you say to Israel? You have an explanation for Israel?
Ma'am, it might be dormant, like it would be slowly growing, and it would have been presented in a late
You
stage,
think that this spleen was slowly growing?
or maybe because of any underlying infection or.
Okay. So this spleen has been there probably from the time this patient was born. That's what we wonder. Okay. So, but is it possible that the spleen came there as an acquired situation? Yes. Do you think that it could have been acquired and been in the mesentery? Well, let's see. Okay. So the diagnosis in this case, it's highly unlikely that this is not being there for, from time immemorial, from the time the person was born. And this is splenic tissue in the mesentery. Okay. Now, how would splenic tissue come into the mesentery? Okay. So you have to get some additional information on this case. And you know that spleen and splenoles in this particular patient were reported on the CT in the usual anatomic site. In fact, I rang the radiologist and I asked, was there a spleen at the usual anatomic site? And he said yes. Okay. And there was no vascular pedicle attached to this splenic tissue in the mesentery, which was lying in the left iliac fossa. And there was no history of splenic or other abdominal trauma. So this case represents an accessory splenic tissue in the mesentery. So Ravi, you were right, but you have to be right for the right reasons and not just for guessing. Okay, good. So now accessory spleens. And how do we define an accessory spleen? It is a spleen which is associated with a spleen which is present in its usual anatomic site. So you have a spleen in its usual anatomic site, and you then have another spleen. And it's amazing, but 1 in 5 persons has an accessory spleen. For all I know, I have an accessory spleen and I don't know about it. Okay, and the most common place where you get an accessory spleen is at the hilum, the tail of the pancreas. But you can get it anywhere along the splenic vessels, in the gastrosplenic ligament, the wall of the stomach, intestines, etc. But in each of these cases, the spleen will be in its usual anatomic site. Now, you can get splenic tissue outside of the left hypochondrium, as I said, as an accessory spleen. It can also be an ectopic spleen. In other words, there is no spleen in the left hypochondrium, and this spleen is elsewhere. And it's often called a wandering spleen. The reason being that it has its anchoring ligaments and the vessels that it drags along with it when it is at some other site, and there is nothing in the left hypochondria. Okay, so and the spleen, this ectopic spleen, can be found anywhere in the abdomen or pelvis, owing to its very long vascular pedicle, because it drags it along with it when it is going. So that's what we call an ectopic spleen. What we saw was an accessory spleen, and you know how we use these terms. It doesn't really matter, but that's the way that it is used. All right. So now let me tell you a little bit about the spleen. The spleen is a much older organ than the lymph node, and phylogeny means how the spleen has actually evolved from the lower animals to the higher animals. Okay. And I'm not going to tell you, you know, what happens in reptiles and what happens in other mammals, etc. But the splenic functions have also evolved. When the spleen was first developed, its first function was hematopoiesis. And you know, they used to tell us that phylogeny, ontogeny, that means what happens during fetal life, how the organs develop, etc., is a mirror image of phylogeny. You know that, no? We even have gills when a fetus is developing. You see those gills, which we call the pharyngeal arches. Yeah, so that you don't see that in an adult, or even when the baby is born. But while the fetus is developing, there are many structures that and functions that recapitulate what was happening during evolution. And so you have hematopoiesis. You know that in the fetus, the spleen is the site of hematopoiesis. Okay, so that is something that the spleen was doing. Of course, erythropoiesis goes on in the fetus in the spleen, but in the adult we have none. Okay, in the earliest spleens, there was no lymphocytes that were performing, you know, an immune function. But as you know, evolution occurred, the spleen gained a white pulp. There was no white pulp in the very early spleens that we saw in early vertebrates, and then specialization of that occurred. And in the beginning, the spleen was involved in innate immunity, meaning it was not adaptive. So there was no question of there being germinal centers and, you know, all our immunoglobulins and everything happening at that time. So there was innate immunity, more or less like how macrophages have innate immunity. And think about it, that this then became adaptive, and you know that germinal centers can arise in the white pulp of the spleen. The next gain of function, because this did not exist in the very early spleens, was RBC filtration. Okay, and so there was specialization. The sinuses became very specialized. They began to show you littoral cells, and the spleen was involved in you know, getting rid of senescent RBCs, as well as in iron metabolism. Because with iron metabolism, you know that finally in the spleen you get bilirubin and biliverdin, which then gets transferred through the splenic vein into the liver, and in the liver it gets converted into bile. Okay, so all of this is on the spleen. And finally, the spleen also is a place where there's this huge vascular sinusoidal network in which RBCs are stored. Now, it is said that when a person is in shock, sometimes the spleen contracts and all this blood is thrown into circulation. I'm not sure whether that is actually true or not, but certainly in large mammals like the big cats, there is a muscularization of the sinusoids. It's almost like a tautology to say that sinusoids are muscularized, but there is a muscular you know, coat around the larger sinusoids of the spleen. And when these animals are chasing prey, okay, and they're running very fast, they need excess oxygenation, and then the spleen literally contracts and you know, pushes out more red blood cells into circulation, so that they get a boost of you know, of red blood cells, so that they are able to get their speed up to. So this is what the spleen is all about, and it has evolved over the years to have these 4 functions. Right now, we've already talked about this, so I don't want to go into this, but this is a diagrammatic representation. You have the central artery, which breaks up into these arterioles, and around the arterioles you have the lymphoid nodules or the Malpighian corpuscles. Around these arteries is what we arterioles. You have periarteriolar lymphoid sheaths. So these are spherical structures, but the sheath is all around these arterioles. Okay, and then of course there's the capsule that is so typical of the spleen, along with its tuberculi. When you see that, you know that this is the spleen. Now let's talk a little bit about this this white pulp. And you were right when you noticed that there was a central area which was, you know, which had a dense area, and there you see the arteriole in the center, and then there was a paler area around the periphery. The arteriole is now here entering into the spleen. And you know, Castleman's disease, where we talk about an arteriole piercing that follicle, it's a lot like what happens in the spleen. Okay, it has a very splenic-like appearance. Now, what are the cells that are around the arteriole in the center, and what are the cells that are in the outer zone? The cells that are around the arteriole in the center are T cells, and the cells that are around that the T cell sheath of the spleen, of the white pulp, are B cells. And because they're at the periphery, they are called the marginal zone. Okay, so this is the marginal zone, and here you are. Here is an arteriole. You can see it at the bottom of the slide. And all these cells, this is the CD3 stain, and you can see that here is the periarteriolar sheath, which is made up of T cells, and eccentrically, because this is an eccentrically cut, Malpighian corpuscle, you can see that CD3 is not marking this outer zone, and that's made up of B cells. Okay. Now, when you go and look at the CD20 of the same thing, you'll see that that sheath, which has now come to the next level when it was cut, is not expressing CD20, so it is CD3. All right. This particular Malpighian corpuscle or white pulp has got 3 zones. You can see an outer zone, which is lighter, a darker zone that is more towards the center, and then you have a less dense zone in the center. Now, this one has developed a follicle with a germinal center. So you have the follicle with the mantle zone, and then you have the marginal zone at the periphery. Now, it's important for us to know that this marginal zone is here. I can show it to you again, and that's the marginal zone of the spleen. This is which has developed this particular splenic Malpighian corpuscle has developed a follicular center. Okay, so you have the follicular center T cells. There is that periarteriolar T cell sheath. Then this is CD3 has not marked either the marginal zone or the mantle zone of this particular follicle. Yeah, I just took this picture because it was very nicely seen. Now, what is the difference between the marginal zone of the spleen and the marginal zone of the lymph node? Did you guys read anything about the marginal zone of the spleen and the marginal zone of the lymph node? Arun, did you read anything about it?
Yes, ma'am.
Tell me, would you like to tell everybody what the marginal zone of the spleen is and how it differs from the marginal zone of the lymph node?
Well, actually, in the marginal zone of the spleen, what happens is there is a high pooling of, apart from B lymphocytes, there is also highly pooling of macrophages and NK cells within the marginal zone. So what happens is, in case of adaptive immunity, whenever there is acquisition of antigens from the B cells in the marginal zone, that goes into the center and it presents the antigens to the T cells in the center, and that elucidates the response.
Okay. So that's what you think happens in the marginal zone of the spleen. Okay.
Yes.
Anybody else? Well, I've given you a little write-up over here. It is absolutely unique because it is located at the interface between the red pulp and the immune system, which is the white pulp. Okay, and this is something that has happened during evolution. And this marginal zone of the spleen is not like the marginal zone of the lymph node, because the marginal zone of the lymph node is a post-germinal center structure. You know, because the marginal zone of the lymph node is outside the mantle zone of the follicle. Okay, so these marginal zone B lymphocytes, they have polyreactive B cell receptors, which the marginal zone of the lymph node cannot have, because since it is post-germinal center, each of those cells will react to only one antigen. But here, this marginal zone cells have a polyreactive B cell receptors on any one of those lymphocytes. They also have high levels of toll-like receptors. Now, I cannot explain all of this over here. These toll-like receptors are expressed in cells which are involved in innate immunity, like macrophages. Okay. So the marginal zone B cells are very specialized cells. I won't say that they're specialized. In fact, they are non-specialized cells that cross the boundary between innate and adaptive immune systems. Okay. Whereas here you see the marginal zone of the lymph node. You see a central follicle. You see the mantle zone, and outside that you get this light area of less densely populated cells, which is the marginal zone of the lymph node. All right. So now, let us see how these behave. After interacting with antigens exposed on macrophages or dendritic cells or neutrophils in the spleen, the marginal zone cells rapidly differentiate into plasmablasts. They do not really need the T cells so this is known as a T-independent pathway. They don't need T cells to really produce this immunoglobulin. And if you compare that to what happens in the lymph node, it is exactly what the mantle cells of the follicle do. Okay, the mantle cells, when antigen is presented to them, immediately produce an IgM response, plasmablasts or primary immunoblasts, and they produce IgM. That's exactly what the marginal zone cells of the spleen do. So they do not resemble the marginal zone of the lymph node, which is a post-germinal center compartment. In fact, they resemble the mantle cells of the spleen in their immunoprofile more than those of the mantle zone of the lymph nodes. Now I haven't got a good picture, so I didn't show it to you, but this marginal zone of the spleen expresses IgD and or IgM, and you think about it, that's what the mantle cells of the lymph node express. They do not show plasmacytoid post-germinal center differentiation as the marginal zone cells of the lymph nodes do. So when you come to the cases, you will note that the margin, and you can read it in your histology or anywhere else, that the marginal zone lymphomas of the spleen are very different from the marginal zone lymphomas of the lymph node. Okay, so you can't use it. What happens after splenectomy? You know that all patients become very, very susceptible to those organisms that have capsules in which there's mucopolysaccharides. So that's pneumococcal pneumonias, hemophilus, meningococcal, and so on. And all of these patients, if they have lost their spleen or there is asplenia, they need to get prophylactic antibiotics. Okay, so that's about the B, and you have the red pulp of the spleen. We have seen all this, and what I wanted to show you about the red pulp of the spleen is that the red pulp, the sinusoidal cells that line the red pulp of the spleen are CD8 expressing. Okay, so they're not lymphocytes, and they are endothelial cells. They are a very specialized kind of endothelial cells. You see that over here. Okay, this is just taken from an illustration somewhere, where the brown stuff is the endothelial cells of the red pulp, and this is stained for two things, and you'll see that the pink is stained for CD34, and this is stained for CD31. Okay, so, and you notice that the sinusoidal endothelial cells do not express CD34, whereas you get these other sinusoidal cells in the spleen, which are not specialized, they express CD34. Okay, and this is important because these littoral cells that line the sinus walls act as filters for altered and senescent RBCs, and they form so they are 30% of the red pulp within the human spleen. Okay, now I'll just tell you this quickly. This is a 48-year-old male who had multiple nodules in the chest cavity, abutting the lungs, and a history of a gunshot injury a few years ago. And you can see all these nodules in the thorax. Okay, and they were found absolutely incidentally when somebody was doing a CT scan for something else. These nodules turned up. Okay, anyone wants to tell me what these nodules are? Since we're talking about the spleen, it's quite obvious that this must be the spleen, and you see the white pulp here, and you see this red pulp over there. Now, how would we prove that this was the spleen and not anything else? Because it is the spleen. Anybody tell me? Can anybody tell me how we could prove that this is not a lymph node that is congested and that these are all congested lymphoid tissue? Yes? Anybody? Medina? Okay, I'll tell you.
I think that
Yes?
there's like a presence of arteriole on the periphery. Can I draw it?
Yes, please.
Yes, let me try.
Please.
Just this one looks like 1 second. This one looks like arteriole to me. This one.
It looks like an arteriole. All right.
Yeah.
Fair enough. But this is a leaf problem, see? Yes.
Kind of sinuses maybe, and so if I can
Sinuses,
see
yeah.
some
But if somebody had to quickly ask you, how would you do this? You know what you would do? What might you do?
Should I do?
What histochemistry would help
I
you?
think CD3 and CD20 should be
CD3 and CD20. Okay, anybody else? Anything in the chat box?
And I can do maybe CD31 to just highlight this in the table.
CD8, ma'am.
Absolutely. Who said that?
Ma'am, in the chat
CD8.
box, there is written from the Goswami N.
Ah, okay. So it's CD8 because we know that the sinusoidal cells in the endothelial cells would express CD8, and there you are. CD8 is expressed. You wouldn't expect to see CD8 in a lymph node or some other structure. Okay. So this is just CD20 that was done, and I just put it there. But here is CD8. Right. So what is this condition? This is splenosis. Okay. So this is another condition in which you can get spleen outside of the left hypochondrium, when splenic tissue has auto-transplanted inside the abdomen or sometimes the thorax, and this patient had a gunshot injury, right? So it must have traumatized his spleen, and the spleen must have, been pushed into by the bullet into the chest in multiple pieces, and that's how this chap got splenosis. Okay, now who's going to take this case? It's very easy. Shambhavi, you want to take this?
Yes, ma'am.
Come on. Read.
Elderly man with pyrexia of unknown origin for 3 weeks. Known case of CML on second line tyrosine kinase inhibitor. VATS biopsy of a consolidation in the lower lobe of the left lung. Second opinion, as the referring physician had received a report of pleural involvement by a myeloid neoplasm.
That's right. Okay, come on now. No prizes to you, Shambhavi. Tell me, what is this?
Ma'am, the section studied shows spleen with an intact capsule, but the white pulp is non-discernible, and the red pulp is expanded, and it appears very cellular. And ma'am, it also shows in the other slides that there is a diffuse mixed population of cells.
Yes, and you see trabeculae, so you see this beautiful spleen. Okay, so this was a VATS biopsy, means they went in and actually, did a wedge resection of what they thought was the consolidation in the lung. Okay, see these trabeculae, and you're absolutely right. There are no Malpighian corpuscles. It's only red pulp, and that red pulp too is very cellular. Yeah, so here you see this. Excellent. And here it is at high power. So what are you seeing over here now?
Ma'am, I see a diffuse mixed population, predominantly of large-sized blastoid cells, and there are a few myelocytes. I can see some band forms as well as segmental neutrophils. And
blastoid cells. Now, where are these blastoid cells?
Ma'am, those big cells.
Which big cells? Come on, you show me the blastoid cells. You ask for annotation. Yeah. So which are those blastoid cells now?
Ma'am, these.
These where I can't see. Oh, those.
Yes,
Well,
ma'am.
they're big cells, but are they? They're just so dense, no? You don't see anything else except there's one or two of them, but the others could be myeloblasts. They could be, yeah. There are metamyelocytes. There are myelocytes, and so on. So what do you think this is?
Ma'am, as a case of the history of CML on treatment was already provided to me, this could be a
Exactly.
case of blast crisis in a known case of CML on
But I
therapy.
don't think there is blast crisis actually over here, right? It is just it's just CML. They went in because he was having a follow-up. He had follow-up, and somebody thought that I mean, he probably did have a pneumonia or something like that, but they didn't hit the pneumonia, did they? No, they hit the spleen, and this patient had CML, and he's got CML in the spleen.
Extramedullary hematopoiesis.
It's not extramedullary hematopoiesis. Why is it extramedullary hematopoiesis? Who said that?
Arun,
Who did?
Arun, ma'am.
Why is it extramedullary hematopoiesis?
Ma'am, I mean, like, because the spleen is involved and we can see all the different lineages.
Right. Okay.
Instead of having this,
So why? Let me ask you. Why is the spleen involved in chronic myeloid leukemia? What is actually happening? Because the bone marrow is producing this, and so when the bone marrow gets overly full, then it gets into the spleen, and the spleen is producing hemopoiesis. Is that
Yes,
is that what you are saying, Arun?
yes, ma'am.
That's what you're saying. Okay, all right. So it's extramedullary hemopoiesis, but it is not like with your compensatory extramedullary hemopoiesis that you're seeing in myelofibrosis or anything of that sort, right? No. Okay. All right. So what's the diagnosis then? This is the spleen, and that the core biopsy needle entered the abdomen. It was not a core biopsy. I'm sorry. This is a VATS biopsy. Entered the abdomen instead of the lung. Okay. So now I finished, and I think Dr. Praveen is going to discuss the rest of the cases. And I just like to say that this lymph node, unlike the lymph node, the spleen does not give up its secrets very easily. You know, you have to coax them out gently. You know that the lymph node, everybody knows everything about the lymph node, and the lymph node is always screaming at you about this, that, and the other. We hardly get to see the spleen, which is always very silent. So thank you. If there are, we can take the questions at the end, I think. Yeah, let me just stop sharing my screen. And Praveen, would you like to share your screen, please?
Yeah, thank you, ma'am. So I'll share my screen now.
I think Praveen has got some very interesting cases.
Give me a minute, please.
No, take your time. Anybody wants to ask any questions in the meantime while Praveen gets his PowerPoint up? Are there any questions in the chat box? Usha? No?
No, ma'am.
No. Okay, good.
Okay, can you see it now?
Yes, we can see it very well. Just need to make it full screen. That's all.
Yeah, so I did it. Who wants to take this next case? Arun? Or maybe Ravi, one of you.
Yes, sir.
So go ahead, please read the history and then start. I'll show the slides.
22, above 25, 59, 14 years old boy, splenomegaly with well-defined 10 into 9 into 8 centimeter parenchymal lesion in the midpole of the spleen.
So this was the only history what we have received, and I suspect that this old 14-year-old boy must have presented with a pain in abdomen. So this is the scanner view. Can you describe, please?
Well encapsulated part of spleen under the underlying parenchymal tissues is a area of so necrosis and congestion.
Okay. So what is the main thing you see on the low part? This on this scanner. That's it. We just talked about it. So you are saying a lot of hemorrhage in the splenic parenchyma, right?
Yes, sir.
Yeah, there is a lot
necrosis.
Yes, and then one part there is a. I will just. So you see this lot of hemorrhage in the blood in the splenic parenchyma, and then this area which I'm highlighting with the laser pointer looks like this has happening something there, right? So we'll go to higher power and check what is happening there. Can you describe it now?
Yes.
Sorry, I think. Okay, can you see?
Yes, sir. Simple dilated spheres of red pulp.
Anybody wants to help him?
So there is a diffuse areas of necrosis, sir. Fibrosis and necrosis can be seen along with areas of congestion.
Correct.
Yes, and also there is some deposits of like looking somewhat like iron and hemocytes.
Okay, that will I think we can go on a higher power and check, right? So in this power, what we can say that there is a lot of hemorrhage in the periphery and in the center here. We can make out that an area which looks like a necrotic area, right?
Yes, sir.
Yeah. What do you see in this image?
Diffuse areas.
Diffuse areas, necrosis. Sorry, hemorrhage.
So yeah, the upper part of the section shows that there is a lot of hemorrhage, and the
Praveen,
part, yes.
Can you go back? Can you just get my request? And just go back. I've asked to annotate. Did you get the request?
No.
Okay. No. Sorry. Okay, let me ask again. Did you get the request?
No, no.
No.
Yeah, now I got it.
All right. Okay. All right. You know, this is what you saw at low power as well as at high power. You know what? Both Arun and what will you say about this? What is this? It was a low power as well as this power thing. If you are describing this, no, what will you say? It's
like
like
wedge-shaped,
Huh?
wedge-shaped infarct or
it's a wedge, yes, but it is so clearly demarcated. You have
Yes.
a hemorrhagic area over here and a pale area on the other side. Yes or no?
Yes, ma'am.
And that
Yes,
is the point that is so evident over here that if you don't mention that, then I think that it hasn't got into your head. All right, sorry. Now, Praveen, you can you can take off the annotation. Sorry. Double click.
Okay. So
You've got a laser pointer on.
yeah, this is my laser pointer. So in this image, you can see there's a hemorrhage, lot of it, and the inferior, the image in the inferior side, you can see there is still some splenic parenchyma can be seen.
What?
So now what is happening here in the next image?
So some kind of a pigment deposition can be seen,
Okay.
and some reticulin, like reticular arrangement of the bluish to black colored at the lower part, lower area of the section. But at the same time, within the tissue, like there are diffuse areas of blackish to blue deposition of pigments, like that could be some hemosiderin with calcium and iron complex.
Okay. So within this necrotic area, you can see something like some deposition is there, right?
Yes.
And then why are you calling this as necrotic actually? How do you know it's necrosis or it's not just fibrin there?
It's not of silver. Yes.
This is amorphous and acellular.
Okay, we'll go
it's
and
more like
hyper
amorphous
check.
and
Okay, maybe there is some high power and we'll check. But anyways, what is this thing which I had just shown you now? Which was outside the section actually.
Elastin.
So it's a
Elastin.
gel
You mean to say elastin stain we have done? This is HNE, right?
Yes, sir.
Okay. Anybody wants to say what it is and why this could have been there? Is it a part of actually normal pathology or something else which has been introduced inside?
It is an artifact.
Okay, who said that?
Somebody.
Okay, Shambhavi. So why do you think it is an artifact and what artifact it is?
So it's a gel foam artifact.
Very good, excellent. So why it is there? Can you
So
guess?
usually during surgical procedures, when they want to control bleeding, they use this. And there is like when we saw the slide also, we can see intraparenchymal hemorrhage and subcapsular like breach.
Excellent, very good. So you can make out that from the images whatever we have seen, that there is a lot of hemorrhage there. And so even they must have gone in to do the splenectomy in order to stop the bleeding or achieve hemostasis. They use this gel foam or gel film, they call it, and they put it in an area where there's a lot of oozing or bleeding out there. And this acts as a framework over which then clot can form or clot can easily form. And so it can stop the bleeding. So this is an artifact which has been introduced during the surgery, right?
Yes, sir.
So it's called gel foam, gel fin, or gelatin sponge. That's what surgeons use usually in the areas where there's a lot of bleeding, like spleen and area. Sometimes when they do the liver resections or the liver surgeries, there also they use this kind of sponge to stop this bleeding. Now, what is happening here in this image? I had asked you the question why it is necrosis and not just fibrin or anything. Why do you say it is a necrosis?
Completely acellular.
Acellular, completely acellular structure.
So fibrin will also be an acellular, no?
Amorphous.
We know this is a necrosis because we can see the ghost outlines of the cells here, right? You can see the ghost outlines of cell, ghost outlines of the vessels here, right? That's why I know this is a necrosis, correct?
Yes,
So what type of necrosis is this?
Geographic.
You know what are the types of necrosis? Shambhavi?
Geographic necrosis.
You must know types of necrosis, right? Arun, what are the types of necrosis and which type of necrosis is this?
It's more like a coagulative.
Excellent.
Coagulative.
Coagulative necrosis. Correct. This is a coagulative necrosis, but this coagulative necrosis is because of what?
Because of like congestion, maybe, or
Because
infarct.
of liquefaction.
No, liquefactive. So is coagulative necrosis a liquefactive necrosis?
Sorry,
Shambhavi?
Sorry, sir.
There is a difference between the two, right? Do you know the difference? Anybody want to help her?
So, I don't think it's a combination of infarct. So,
Yeah, this is an infarct. Correct. I agree. So infarct is a type of which necrosis? Infarction necrosis is a type of coagulative necrosis.
coagulative necrosis.
Because you see that there is a coagulation here, there is a complete ghost of cells which you can see. There is no proteolysis or cells are not lyse. You can see the outlines of the cells. That's why we call it coagulative necrosis. And infarction is a one type of coagulative necrosis, right?
Yes, sir.
Then tumor necrosis is also type of coagulative necrosis. So how it is different from a liquefactive necrosis?
Usually, side.
It's a liquefactive brain metastasis.
Yeah, but brain, how many times do you see brain? There must be some example which you see maybe, quite often.
You can also see it in bacterial infection, liquefied necrosis, and it should look in a different way.
Excellent. What Madina said is correct. Whatever pus or abscess you see, that is a liquefactive necrosis because you don't see the cell outlines there.
Yes.
Everything is lies. So that's why it forms a liquid or jelly-like thing. That's why it is called liquefactive. Correct? So here this is a kind of coagulative necrosis, which is a kind of an infarction necrosis, right? But can you tell me an instances where it is so important that we need to differentiate even infarction type coagulative necrosis versus tumor coagulative necrosis? Do you know any organ wherein it becomes so important, wherein it hinges whether you want to call something malignant or something benign, or rather something differential of the malignant?
Breast.
Sorry?
Breast malignancy.
I don't think it is so important there. Okay, I will give you a hint. It is in uterus. So there are tumors in uterus where you want to know, it is a spindle cell tumor in the uterus, where you want to know whether a tumor having atypia, then it hinges on to know whether it is infarction necrosis or coagulative necrosis, wherein if there is a coagulative necrosis, you make a diagnosis of malignancy.
Leiomyosarcoma.
Exactly. Excellent. Smooth muscle tumor in uterus, when you have something which has got a nuclear atypia, then you would like to see if there are areas of coagulative necrosis. If there are coagulative necrosis along with mitosis, then we make the diagnosis of leiomyosarcoma, right? But the tumor having nuclear atypia but no coagulative necrosis and usually infarction type necrosis, then you cannot call it. You'll have to think about it calling it leiomyosarcoma. You might call it then STUM, smooth muscle tumor of uncertain malignant potential. So now, can anybody tell me how infarction necrosis there is different from the coagulative necrosis of the tumor? So I will tell you, sometimes it can be difficult to even dare to say whether it is infarction or coagulative, but most often you'll be able to say, because in infarction necrosis, usually what you have that the area between the normal or uninfarcted or unnecrosed tumor and the necrosed tumor will have something like there will be some foamiosteocytes or some inflammatory response, or there will be fibrosis in infarction type necrosis. Even the blood vessels will be completely necrosed, like here what you see is the completely necrosed blood vessels. Wherein if it is a coagulative necrosis, you don't see that ream of fibrosis or foamiosteocytes between the non-infected or non-necrosed tumor and the necrosed tumor. And in blood vessels are usually intact, and you see the tumor around the blood vessels because the supply it is getting from that vessel, and you move away from the vessel and you start to see the necrosis. These are some short pointers where you can actually make out whether it is infarction necrosis or coagulative necrosis, right? Now tell me what is happening here in this image only in the corner, on the right hand corner, or we can go on the next slide and then check what is happening here apart from necrosis.
Some pigment
deposition, sir.
Yeah, excellent. So there are some deposits which are happening around the vessel wall, right? And also within the parenchyma. Correct? Yes. Again, in this image also you can see that here it is around the vessel. There is something which is brownish to black deposition which has happened around, right? Similar thing can be seen again in this image, right? So what are these things? What is it called?
Deposition of pigment deposition.
So what are these pigments and how they are formed?
Maybe
because of hemophagocytosis.
One at a time. Okay, who's saying this? Arun.
Sir, because of ingestion of RBCs by the macrophages, that will release hemosiderin, and that leads to deposition of hemosiderin. That will in turn attract other elements such as iron and calcium, which imparts the color which is seen in.
Excellent. So these are called
gamma antibodies.
Very good. So these are gamma antibodies. Okay. Now, so splenic gamma antibodies are usually found in benign conditions, right? They are usually found in pathological conditions like portal hypertension, in sickle cell anemia, in hemolytic anemia, or there is splenic vein thrombosis. And as you rightly said that these are due to result of extra what is the RBC which gets lyse and release the hemosiderin, and along with that there is a deposition of calcium, and that the entire thing forms a fibrotic nodule. That is what we call as a gamma antibodies. Correct. So what is now the diagnosis for this case?
So congestive spleen.
Okay, but there is something more which has happened here, right? And we talked about it, about the necrosis.
Coagulative necrosis.
Yeah. So what? So we have. So what type of necrosis it was? Coagulative necrosis, but infarction necrosis, right? It was because of the splenic congestion, probably because of the venous congestion or venous block which might have happened, and that's why there is a infarction necrosis. So this is an infarction, hemorrhagic infarction of the spleen, and there could be many causes for splenic infarct. Usually it is related to hematological malignancies like leukemia or lymphoma or myelofibrosis. Sometimes it is because of hypercoagulated states like sickle cell disease or protein C and S deficiency, polycythemia rubra vera, lupus anticoagulant, or exogenous estrogen use or malignancy, or thromboembolic disorders like atrial fibrillation, endocarditis, patent foramen OL, or prosthetic heart valves. Now, what you have to remember is that if the patient is below the age of 40, usually the hemorrhagic infarction is caused because of the hypercoagulative states. And if the patient is elderly, more than 40 years age, the most common causes are usually related to thromboembolic phenomena. And sometimes it can be due to blunt abdominal trauma as well. And rarely it can be because of pancreatic disorders like pancreatitis or compressive pancreatic masses. But sometimes iatrogenically also splenic infarcts can happen, when they're trying to embolize the patient. Like let's say they are going to operate on spleen and they give that embolic inject something to embolize the artery. Then also you can get the hemorrhagic infarction of the spleen. Okay, so we'll move on to the next case. Who want to take this case? Anybody? Dr.
May I-
Medina?
Yeah. So
Yeah,
can I
please.
start with- Yeah, this is a case of 43 years old female presented with a pain in abdomen. CT scan was suggestive of splenic SOL of lesion. I mean, 9 to 8 centimeters splenectomy was performed.
Okay,
Um,
so these are the CT images, right?
yeah,
So can you show where is the spleen here?
I think. How should I turn? Let me.
You can ask for annotation.
Yeah, 1 second. One
Okay, there
second.
are two images, right? One is on the right hand side, which is what is called a transverse plane or axial plane. So on the right side image, where is the spleen?
I might be wrong, but I just feel like it's.
Yeah, try it, no? Because even as a pathology, yeah, correct. That is actually you have highlighted a lesion within the spleen, but the entire spleen is this here.
So here is. Okay.
Okay.
Yeah.
And in this other image, this
Yeah.
is the spleen.
And here is this space
Correct.
occupied stem.
Yeah, very good. So this is what was seen there because it is such a large lesion. That's why they had to go in and take out the spleen. Okay.
Adina, what is this? Where my arrow went?
Yeah.
Can you see that? Next to the spleen, which has like an area in the center. And I'm sorry, maybe I take another color. You can't see it.
Yeah.
You can see, man. Your blue arrow is there.
Yeah. So what is this? What is this organ?
I don't know. It looks like stomach to me. Maybe I'm.
It looks like what? Correct. What is it?
Very good. Yeah.
It's the stomach. Excellent. Yes, it
Very
is. That's the
Stomach
stomach.
is-
There's the liver.
The space
Just
where
there.
this gap is.
Excellent.
Where
Yes,
the
it is.
gap-
There is a kidney turning up over here. You can see. There's another. You can see that. Okay, good.
Very
Excellent.
good. Yeah. And it looks like there are contents within the stomach also.
Yes.
Yeah. Okay. So we'll go to the next. Okay. I think.
Should I read the caption on the city image, or it's not required anymore?
Okay. Now this is the gross image, right, Madina?
Yes.
Would you like to describe now where is the lesion here on the cut surface?
So I think it's mostly. So if I'm going to use the CT scan image that we have already seen, so it should be on this pole, I guess. I cannot draw anymore.
Annotate? You can't draw? Okay, I'll give that. Yeah. Now
Yeah,
try
so
to. Yeah.
the cut surface reveal, I mean, uneven structure. I think this looks like a. I cannot draw. I don't know why. I
You
think
can't
this looks
draw?
like. Yeah, this looks
Ah,
like.
correct.
Yeah, this area looks
Excellent.
like it has uneven
Yeah.
structure. It doesn't show normal splenic parenchyma. So I think this should be like this lesion formating area.
Yeah, very good. So this looks like this is a complete lesion here, right? What have you
Yeah.
drawn? It's a complete lesion here. It looks quite brown, and there is something happening in the center of the lesion also. Looks like there is some scar.
Fibrous.
Yeah, fibrous scar like thing. Yeah, correct. That's correct. So this is what the lesion which was seen, right?
Yes.
Now this is a microscopy. Can you describe?
I can see normal, like the remnant of the normal splenic architecture on the right side, on the upper side, and this area looks completely kind of changed because of the. I cannot surely say is it like necrosis. But, can we get the higher magnification of?
Yeah, okay, we'll go on the high power, but you are absolutely right that there is a lesion which is nicely demarcated from the normal splenic parenchyma.
Yeah.
Okay.
And there is like remnant of the normal trabecle on the side.
Yes, correct.
So I
That is
think
the upper side of the image. This is a normal remnant with the with the follicle and red pulp, and then you have this very sharp demarcation, and then there is a lesion which I think vaguely appears nodular at least on this power, and then we'll go on the high power and check. Now, what is happening here?
So I can appreciate this nodular architecture. Oh my gosh. I can appreciate this nodular architecture here, which is kind of divided by fibrous septa, but it's showing, it's not showing normal splenic architecture anymore. It's showing definitely nodular architecture, and let me see.
Yeah, very good. So you can see that there are nodules which are back to back, quite close to each other, and they're separated by something looks like a fibrous tissue, right?
They are separated by this fibrous septa, and it's showing complete effacement of white and red pulp with the presence of nodular lesions.
Very good. So what we can judge now that there is a lesion in the spleen, well demarcated, and it is composed of these nodules. And then now we'll go on high power and check what is happening in these nodules actually. Okay, so this is one of the nodules, right?
Yes.
So what do you see now?
I can see this like little spaces here. This, I mean, in an inter area, these little spaces like, and
very good.
even
So they look like vascular spaces. Yeah.
Yeah, sorry. And I can probably see there is some fibrous kind of septus even in the center of the nodular formation, and there
Right.
is increased number of vascular spaces among with the presence of fibrous septa, and I think this is like thickened maybe vessels here, thickened vessels with
Okay.
vessels with thickened wall, I guess.
Right. So you can see different type of vessels here, right?
Yes.
And when you say there are spaces, and I said they are like a vascular spaces, how did I know that these are vascular spaces?
Because we have already, on a normal splenic parenchyma, we can
Yeah. So
already
even on the low power, we can go on high power and check, but even on low power, one can make out that there probably are endothelial cells which are lining this, right? So any spaces if it was endothelial lining, then that has to be vascular space and not just a pseudo space, right?
Yes.
And you rightly said that there are different type of vessels are there which are proliferating within this nodule. There is some extravasation of RBC you can make out, and then there are some fibrosis within these nodules as well. Let us go to the next image. Now what is happening here? This is high power.
Okay, I can see increased number of RBC on the slide, among with the presence of vascular channels, and among with the kind of abundant endothelial cells, which is lining vessels, and
Yeah, correct. So what you see is that what catches your eye is that there is this extravasation of RBC, and then in between you see these different size vessels are there. Some are quite slit-like, and some are quite open vessels, and they're lined by this endothelial lining. Correct. Which is exactly plump endothelial cells, but there is no ATP or mitosis in those, right? And cells don't show here, at least in this power, you don't see in the vessel there is anything like wall is there. They look like they have probably only the endothelial lining. That's how you recognize that these could be sinusoids, right? This is another power. It's a similar thing what you just described. Again, there is extravasation of RBC, there are vessels. In between, there are this spindle cell proliferation also there, which probably look like they are also bland, these cells, and they look like this could be fibroblast. Okay, that's how it looked like it was fibrotic. So what are your differentials? What is, and out of which, how do you say which is the diagnosis?
I think that's benign, first of all. I don't think that is malignant, so we have
Excellent.
to
Okay.
say that that's benign. And second of all, I can see increased number of RBC and what else? And increased number of venous sinuses and plump endothelial cells. But
So in
it's not.
a broad sense, what type of lesion it is?
I think it's
Is it a
benign.
lymphoid lesion or mesenchymal lesion?
Mm,
It's a mesenchymal lesion, right?
Yes.
yeah.
In
I
broad
got
spectrum, it's like a vascular lesion, right?
Yes.
Yes.
But it has got at least good number of vessels.
I was thinking about hemangioma or lymphangioma, but it doesn't look like hemangioma or lymphangioma
Okay.
because that is not what it should
Okay.
look like.
Any other thing in spleen which is
malformation of the spleen could be in my differential.
Littoral cell angioma.
Littoral cells esclosing into required nodular transformations and
okay, great. Okay, so we have 2-3 differentials here, right? One is littoral cell angioma, another is whether it is a SANT, which is sclerosing endometrial nodules
Hemangioma.
transformation, or hemangioma, right? So what we see here that there are these nodules, you can beautifully see in this picture, which are confluent nodules or rather very well packed nodules, and then there are vascular channels, there are bland looking, which are lined by these bland looking endothelial cells, there are exavasated RBC, and of course there are bland looking spindle cells and few inflammatory cells, probably there are some lymphocytes are there here and there, right? So these are, as you all have rightly said, there are the differential diagnoses. One could think of hamartoma of the spleen, hemangioma of the spleen, littoral cell angioma or lymphangioma. One could think of SANT, and then there are malignant or like hemangioendothelioma or angiosarcoma. Now it is not malignant, which even Dr. Madina made it quite amply clear because they hardly see any ATP or anything, no mitotic activity. So angiosarcoma is out. Hemangioendothelioma again should have channels which are lined by atypical cells, which are not there. They look quite bland cells. There are no blister-like cells. So hemangioendothelioma is out. So there are the other differentials are there. Now lymphangioma is usually, if you're seeing, it is more like a honeycomb-like cystic spaces which are filled with proteinaceous fluid or sometimes lymphocytes. So that also it doesn't look like. So coming to the littoral cell angioma is usually, it has got anastomosing vascular channels which are lined by tall columnar endothelial-like cells. These are not like these bland endothelial cells, and they usually can sometimes show you occasionally papillary fronts. That's how the littoral cell angioma looks. It is never looks like we're so well demarcated, and on grossly also it's not like this. Whatever you're seeing like a solid lesion, it usually has some cystic areas in that. So overall, it doesn't look like it doesn't fit into littoral cell angioma. And what is a specific thing about littoral cell angioma on immunohistochemistry that the lining cells have both vascular as well as it has got somehow histocytic differentiation. So it will have a histocytic marker positivity, which is CD68, and CD31 positivity, which is a vascular marker. So so this is how little angioma look. In hemangioma, yeah, one could think of, but it has, like you have capillaries and cavernous hemangioma. It certainly doesn't look like any one of those, wherein there will be vascular spaces which are, separated by thin fibrous septae within the red pulp. Hamartoma is something which is a unique thing which can occur in spleen, wherein you have disorganized vascular channels which are within the red pulp actually, or red pulp like stroma, and it is usually not so well circumscribed lesion. So that is also unlikely. What it best fits it to, like, it is like a sclerosing angiometric nodular transformation, where you see that it has got multiple confluent nodular nodules and surrounded by concentric fibrous rims. It has got three types of vessels, which is one is sinusoidal type of vessels, then capillaries, and then the small veins. And these vessels are very different profile. Sinusoids usually express CD8, and they don't express CD34. All of these are actually express CD31, which is a vascular marker. So sinusoidal will express in addition to CD31 will CD8. Capillaries will express CD34 and CD31, but they don't express CD8. And small veins usually express CD31 only. They don't express CD34 or CD8. So keeping in this mind, immunohistochemistry, if you see, so this CD31 would mark everything, right? I think Dr. Fodeke, if you can please mute yourself. So CD31 marks all the vessels, right? Sinusoids, it will mark capillaries and veins also. So you can see that's why it looks quite busy on CD31. When you see the CD34, you start to see these capillaries are there, So capillaries, it has marked the capillaries. And on CD8, you can now see that there are these sinusoids which are marked by CD8. So it has got all these three types of cells, vascular channels. So it is sclerosing endometrioid nodular transformation of the spleen. Okay. So we'll move on to if you have to know something about sand, these are usually vascular lesions which are only described in the spleen. You don't see or anything like this even outside the spleen. That's what they say. You will never see anything outside the spleen. It is very peculiar to the spleen. Usually occurs in middle-aged people with female predominance, and we, as of now, do not know what is the pathogenesis of it. They usually present as asymptomatic masses, most often incidentally detected, and can have non-specific symptoms like abdominal pain, nausea, vomiting, anemia, or malnutrition. And sometimes it can be found in setting of some other malignancies, but this lesion itself is benign, and it never doesn't recur or shows any malignant potential. Splenectomy has to be done like this, which was a large lesion, because in order to avoid spontaneous rupture, so you have to do the splenectomy. And we'll move on to the next case. Who want to take this case?
I'll take it, sir.
Okay, go ahead, please.
So a 60-year-old male presented with a large splenic mass, and the gross showed a gray white lobulated tumor which is measuring 12 centimeter in size.
Okay, so this is a scanner view. What can you say on this scanner view?
Sir, we can see that there's a clear demarcation of the lesion from the rest of the tissue over the right side.
Okay, so correct. So this is a large tumor here, right?
Yes.
This is clearly demarcated from the rest of the normal appearing splenic parenchyma. So what do you visualize? We don't have a gross picture here. I'm sorry. So what can you visualize that how this lesion could have been like?
Sir, it more look like a diffuse involvement, like continuous diffuse involvement.
Just now you said there is a demarcation. Then why you are saying diffuse involvement?
I mean, the lesion which is involving, the place where it is
So
involving.
must be a well demarcated lesion, mass forming lesion. Most likely gray white tumor like lesion, which is there within the spleen, and you could make it out or separate it out from the normal splenic parenchyma, right? That's what I think we can visualize, at least looking even at this scanner image.
Yes.
Now you move ahead and see the low power. What do you see here?
So here we cannot actually identify the clear cut. I mean, it's completely filled with lymphocytes or lymphocytic population. We cannot clearly identify the white pulp per se.
Excellent. So you can't identify red pulp or white pulp or anything else, right? It looks like there is a monomorphous, or rather, at least on this power, there is some population of atypical cell. That much you can see, right?
Yes.
So you want to see now next power?
Yes.
Okay. This is another image on the same low power. I think it's again showing the same thing. Yeah. So we'll go on to another little higher. Now what have you started seeing here now?
Sir, I can see that these like there is some kind of a hyalinization which is happening in middle of the cells. These atypical cells are small, and usually they are showing the basophilic.
Why do you say they are small? Can you on this power make out is it small or large?
No, sir. Like we cannot clearly say if it's really small or large, but could be small, more possible.
So at least what we can judge here that there is a monomorphic population. At least one can say, at least on this power, and it has got some sclerosis in between, right? And
yes.
Most likely it is we are dealing with something which is a lymphoid population, right? It doesn't look like something else like epithelial cells, right?
Yes.
Yeah. Okay. Then now we'll move on to this power. Now you tell me, why do you think it is small or large, or how do you make something is small or large if you think that these are lymphoid cells or it is a lymphoid lesion or lymphoid neoplasm?
Sir, like as I said that there is fibrosis in between, but here also like it's more like I could say that there is some kind of a pleomorphism, but almost like more or less the same. Like the cells are more or less the same.
Yeah.
Some sort of pleomorphism can be seen.
Yeah, very good. There are some few large cells here. Some pleomorphism is there. Okay. Now we'll move on to the one more area here. Now you tell me, by looking in this picture, can you say what cell size this is for a lymphoid? Neoplasm. You have to see what size it is. Whether it is small cell, or it is a large cell, or it is intermediate cell. Because that's how you then try to differentiate the different differentials when it comes to your mind. Whether it's a large cell lymphoma, or a small cell lymphoma, or whether something which is intermediate.
It's like an intermediate. It's like an intermediate.
Okay. And how do you judge that?
Definitely not large, because at this point, I guess if it's a large cell, then definitely it should be small.
So there has to be something against which. Sorry, who?
We have to compare. Like there is no.
Exactly. So how do you compare? How do you say something is large?
Small lymphocyte based on small.
Sorry, who's Madina? Yes, you want to say something? Please go ahead.
Yeah, I was saying they are having almost the same size as RBC, so we can say that they are like more intermediate than
Okay,
large.
let's say then we should find an area where you can at least see some RBC or some lymphocytes. Now, can you see here there is some RBC?
Yes, sir.
Can you see this laser pointer? Now
Yeah.
tell me if that is an RBC or even something here, it looks like maybe a lymphocyte, right?
Yes.
A small lymphocyte. Now compare this RBC and lymphocytes. Usually RBC and lymphocytes have same size, right? They're almost 7 micron like. So now you tell me what is the size of these cells?
It's larger than.
Exactly. They're almost double or more than double, right?
Yes.
So that means it is not a small cell lymphoid neoplasm. It looks like it is a large cell lymphoid neoplasm. Correct? It is almost twice or thrice, maybe even 4 times the size of the small lymphocytes and RBCs. That's how you judge. If now something looks like that size of the small lymphocytes or RBC, then it is small lymphoid. If it is slightly large, then you think it is intermediate. If it is double the size or more than that, then you think it is large cell type. Okay. So what we see is here something which looks like a neoplastic thing because they're so cells which look quite similar to each other, and that's why we think it is going to be large cell lymphoid proliferation. Okay. So what will be the differentials then in this case?
No, sir.
Yes, sir. Yes. What will be the differentials, Ravi?
Sir, DLBCL follicular.
Very good.
Follicular.
Okay. So did you see the nodularity in this? Or follicularity, that means it looks more diffuse, right? If there were no nodules or follicle-like thing, then unlikely it will be follicular. But if there were nodularity, one could have thought of follicular grade 3B, right? Which now is called follicular large B-cell lymphoma. But here it looks more like a diffuse thing without any nodularity. So yes, DLBCL or diffuse large B-cell lymphoma is a differential.
Marginal.
Anything other you can think of, any large cell lymphoma, which is not a B-cell lymphoma? Do you think of anaplastic large cell lymphoma in this?
Yeah, it could be.
Can it be a differential?
But the pleomorphism is not that highly.
Not necessarily. You don't need to. There is something which is hallmark of that thing. Is it seen here? For ALCL, there is something we say a hallmark cell, So hallmark cells are like embroid cells or reniform cells, which you see in ALCL, which are not there in this. If those were there, one could have thought of that differential also. And obviously, when you do the immunohistochemistry, whether it's B or T or null site, that would give you more an idea. So now we have large cell lymphoma as a differential here. So what do you want to do? What IHCs you would like to do? Immunohistochemistry.
CD19, 21.
CD19, anything which is more commonly used. CD19 is not very commonly used. 20. Very good. So CD20. So we use CD20 very commonly used marker to say whether it is a B-cell lymphoma, right?
Yes.
And then which other marker we use commonly to say it is a T-cell lymphoma? CD3. So we always use CD20 and CD3 in a pair to see. So most often these two markers will give an idea whether something is B or T. Very rarely something will be CD20 negative B cell, and very rarely something will be CD3 negative T cell. So you use them in combination to make the diagnosis. So this is a CD20. Can you see that 20 is nice and diffusely positive, right?
Yes.
This is a CD3. Upper two images are CD3 and CD5. So what are these? These are both are negative. Why do you think I have kept them side by side to check if it is really? Sorry. Can anybody tell me why I have kept CD3 close to against the CD5 also to compare? Because CD3, CD5 both are T cell markers, but CD5 is expressed in B cell lymphomas as well. So when if it is expressed in B cell lymphomas, even though it is a T cell marker, you have to think of few special lymphomas like sorry, correct, CLL, SLL. Any other lymphoma which is CD5 positive?
And a large cell lymphoma could be CD5 positive as well, but it should be ALK positive.
Yeah, so if it is ALK positive anaplastic large cell lymphoma, it will be, but there are ALK negative anaplastic large cell lymphomas. Mantle cell, excellent. So you have CLL, SLL, and mantle, which are there. Very rarely also B cell, large B cell or diffuse large cell lymphomas can be CD5 positive, right? Yes. But these are very rare things. Okay. So that's why you have to compare whether 3 against the CD5. Okay. Now this is a CD10. So CD10 is a positive. Okay. Then you go to next marker, which is BCL6. BCL6 is also positive.
Yeah.
Then you go to the next marker, MUM1. So MUM1 is also positive. Now all these 3 markers, 10, BCL6 and MUM1, as a part of something what we say is a Hans algorithm. Okay, I'll come to it. Okay. And you have to do it now in all large B-cell lymphomas, except for very few special lymphomas like mediastinal large B-cell lymphoma. You probably don't need to do these markers to say whether it is called as something like a GC-like or German center B-cell-like or ABC or activated B-cell or non-GCB-like types in diffuse large B-cell lymphoma, right? Then you also do something called as c-Myc and B-cell to know whether there is c-Myc expression or B-cell expression. If both are expressed in large B-cell lymphoma, then these are called double expressed large B-cell lymphomas. Okay, so c-Myc here is negative, but B-cell2 is positive. Okay, and MYB is quite high, almost 90% it is. Yeah. So what are the positive stents which are there? CD20, CD10, BCL6, MUM1 and BCL2, and negative stents were CD3 and CD5 and c-Myc. And Ki67 is quite high, more than 90%. So this is a diffuse large B-cell lymphoma. If I have to categorize by GCB by Hans algorithm, it will be GCB-like because it is CD10 positive, right? And primary splenic DLBCL are not so common. But whenever they occur, they usually occur in young patients. They present with high LDH levels and present as abdominal pain. Patient can have these symptoms like fever, weight loss, and present with splenomegaly or focal splenic lesion. This is what is called as Hans algorithm here. When you use three markers, CD10, BCL6, and MUM1. If CD10 is positive, it is a GC-like subtype of large B-cell lymphoma. You don't need to even do BCL6 or MUM1 if it is CD10 positive. But let's say CD10 is negative, then you do BCL6. If the BCL6 is also negative, that means CD10, BCL6 both are negative, then it is non-GC. That means non-germinal center-like. When you do BCL6 and BCL6 is found to be positive, then you do MUM1. If MUM1 is negative, then you still call it GC-like. If MUM1 is positive, then you call it non-GC-like. That's how it is. And WHO recommends that all diffuse large B-cell lymphomas should be categorized according to the Hans algorithm, because that gives you more a prognostic thing, because GC-like do better than non-GCP-like. And there are some studies which are going on to check if whether it makes even difference in chemotherapy response. So this is how it might have looked. This is what I have taken from the net, that this is very large lesion within the spleen, which is gray white. Any other differential could you think of for this on this gross image? Because it's very important. Sometimes you get the spleen. Even
Sir,
like
usually the larger lesions usually can, if it is associated with septal fibrosis, can be a Hodgkin's lymphoma in the spleen.
Very good. Yeah. Anything else? So it can be DLBCL, it can be LCL, it can be Hodgkin's, it can be a non-lymphoid tumor, right? It can be like IMFT or inflammatory myofibroblastic tumor, something like that. Okay, inflammatory FDC tumor. So all these will be the differentials when you see a large lesion in the spleen. Okay, these are also images from the net I have taken, because sorry, I don't have good images of the spleen pathology. So this is on the left side. A image. What is it showing?
Diffuse red pulp.
Diffuse red pulp thing. So what are the differentials when you see the spleen which is completely enlarged and all this red pulp?
Hairy cell leukemia. Hairy cell leukemia.
Very good. Anything else?
Even like the one which we discussed, congestion. If there is any congestion.
Yes.
There's an obstruction of the venous congestion.
Yeah, very good. So you have to think like that, when you see something like this, either it is just a congestive splenomegaly, or could it be neoplastic, something like hairy cell leukemia or the diffuse red pulp lymphomas. All those things will come into differentials. And on this B image, what do you see?
Nodular white pulp like proliferation.
Yeah, so this is small nodular, right? It's not like large nodular, it's small nodular. So what will be the difference?
Mantle cell.
Okay, so something the lymphomas which can form small nodules, right?
Yes.
So one is a mantle cell.
Biliary TB or tuberculosis.
Very good. Even TB can cause this kind of thing. Excellent. It can be follicular lymphoma can form this, right? It can be even splenic marginal zone lymphoma. It can be CLL, SLL. So all those differential will come into the mind, right? Small nodules which are there in white pulp. Okay.
Yes.
So now so just to give you some idea about primary splenic lymphoma. Yes, usually the spleen is reported to be involved in 15 to 40% of all non-Hodgkin's, not just primary. Okay. And some people have said that the spleen is involved in autopsy in 50 to 80% of the tumor, lymphoma cases. But these are not considered primary splenic lymphomas. Primary splenic lymphomas are very few. They just constitute 1 to 2% of all lymphoma cases. And most commonly these are, if you have primary splenic lymphoma, then most commonly these are small B-cell lymphomas, like splenic marginal zone lymphomas, and then splenic mantle cell or follicular or hairy cell leukemia. All those will come into the picture. And sometimes you can have a DLBCL subtype, which we saw in the case, but these are less common. Okay. So we'll take this next case. Who will take? Anybody? Who wants to take? Photo K? You want to take this case?
All right, can you hear me? Okay. So this is a case of a 75-year-old male who presented with anemia, thrombocytopenia, and splenomegaly.
Okay. Now we'll go to the scanner image. This is the entire slice of, which has been scanned. So what do you see on the scanner image?
So this is a micrograph of splenic tissue showing an intact capsule, and there are obvious white pulp and red pulp.
Okay.
And enlarged. Okay, I think.
You want to go into the more high power? Another power you want to go? Okay. Now describe this. Yeah.
Okay.
Yes, tell me please. Anybody wants to help him?
Okay.
Sir. Yeah.
Lymphoid follicles. Many lymphoid follicles embedded in red pulps.
Yeah. So it is looking busy, right? You can see different types of nodules of the lymphocytes within this red pulp. Okay, which appears to be more than what you expect in a normal spleen. That much at least one can say on this low power, right?
Yes.
Okay, then we'll move on to another power. Now, what do you see here now? You have seen the normal histology. Madam has just shown you the pictures. Now, if you compare those with this, what is different about this?
It looks like the margins of these cells are margins of the white pulp is kind of involving or spreading into the red pulp.
Okay. And so something is spilling into the red pulp.
Yes, right? Spilling into the red pulp. Yes.
Very good. And these nodules are expanded.
Expanded. Correct? Yes.
Now this is low power. You want to see the high power. Now this is again red pulp. What is happening here in red pulp? We'll come to the nodules again on the more high power. But what is happening here?
There is infiltration of
Correct. So it's trying to form this very small micro nodules like thing, right? Within the red pulp also, correct?
Yes.
Apart from those large nodules. So something which has involved the white pulp also, and then
Sorry.
it has involved the
red pulp.
red pulp also, right? This much one can say. And now we can say for surely that this looks like this is going to be a neoplastic pathology. So, correct?
Yes.
It doesn't happen in the normal spleen. This is another view, same thing in red pulp, which is showing now more micro nodules, correct? Now this is a high power of that large nodule. Can anybody describe?
May I?
this-
Anybody wants to say anything?
Yeah, so this morphic corpuscle is showing the effacement of normal architecture by
Very
the
good.
presence of void infiltrate, because we cannot appreciate the zones. I mean, we cannot appreciate the germinal center, we cannot appreciate the marginal zone. It looks completely, I mean, effaced by the presence of infiltrate. So there's no zonal separation between them. And
Excellent.
this pulse area is also showing infiltrated by these lymphoid cells, because we cannot also appreciate this area as well.
Correct. So the as you rightly said, you cannot see the different zones, you know, the dark zone in the center, then followed by small pale zone, which is you see normally in that follicles of the splenic follicles. Here something it looks like everything is merged here actually. And you might say that there is little bit of some dark zone, but still there are quite a few pale cells within this zone. And then it is surrounded by this very more pale looking cells. So it has expanded and the architecture has actually gone. So something has infiltrated also within the center of this follicle, correct? So we'll go to the next. This is another image. It's showing almost the same thing, right? Same thing here. Maybe there are some more dark looking cells here in the center. There seems like there might have been some follicle remnant here, or maybe some FDCs there. And then surrounding there are this complete expanded zone of more paler looking cells, right? This is what it is looking like. It is not a normal follicle, that's for sure, right? So what it is composed of now, it is more another high power. What size of cells are there? At least that you
Medium
can.
size. Medium size cell.
We need another. We need to go into still higher power to confirm.
Okay, this is an high power. Tell me.
Yes.
What is small
Medium
cell?
size cell.
Yeah. So these are small cells, right? Most of these are small cells. They are very almost looking monotonous, but there are small cells in between. There might be few large cells here and there. Few large cells here and there, but mostly these are all small cells. Some of them have quite abundant cytoplasm, so it has got some pale look to cytoplasm is there. So you have, this is very monotonous appearing, small lymphoid cell population, and very few maybe large cells here and there. Okay, this is the red pulp area. Again, if you have to see, there are similar type of cells which are infiltrating into the cords of the sinuses also, and they are also within the sinuses, right? So within the sinuses and the cords, the similar looking cells. So something which has not only involved the white pulp, but also has involved the red pulp as well, correct? And the cell size is small. So what are now the differentials here?
Splenic marginal.
Small
Splenic
lymphocyte.
marginal lymphoma, sir.
Very good. Any other differential you could think of?
CLL. CLL.
CLL, SLL, very good.
Nodal marginal lymphoma.
Mantle
Okay.
cell, but it's not
Mantle cell
just-
lymphoma, very good. So I think you are all right. This will be the differentials. Why it is not just a hyperplasia? Can anybody tell me?
So if it is hyperplasia, they will not be spilled over into red pulp.
Very good. Excellent. So if it was a hyperplasia, you don't see any spillover to the red pulp, right? So that's why it has to be lymphoma. And then these differentials all will be there. Something which are differentials for small B cell lymphoma, which have nodular architecture, right? Which are splenic marginal zone lymphoma, CLL, SLL, mantle. Can it be follicular lymphoma?
because it's still modular.
So usually follicular lymphoma doesn't cause red pulp involvement.
Okay.
Only very fraction amount of small follicular lymphomas will cause.
Yeah. So another thing is you see the cytology, right?
Yes, sir.
For follicular lymphoma, you have to have centrocytes also. These cells doesn't look like centrocytes, correct? If you have to think of mantle cells are usually small cell, but they are slightly clued cells. These again were not so clued cells, right? So that way, even on just looking at HNE, one could think of it is that it may not be mantle, it may not be follicular, but of course you have to go ahead and do the immunohistochemistry for confirmation. And so this is the immunohistochemistry, right? I think I have not labeled it down. These are the first two images are actually CD20, these two. So CD20 looks positive, right? In the nodules, within the white pulp as well as in the red pulp, everywhere it is positive, right? This is actually BCL2. I forgot to add here, but this is BCL2. What is different from CD20 here, this BCL2? Anything you want to say?
Bright
Look
positive.
at this image. Where my arrow is, where my pointer is. Can you tell me what is happening here? Is it similar to CD20 or it is something different?
The germinal, I mean the center of the follicle is staining negative. It didn't stain.
Excellent. Very good. So was it expected to stain or it was not expected to stain?
Usually it is expected.
Not
No.
still.
So,
Usually no.
no. So correct. In usually the germinal center B cells are BCL2 negative. Germinal center B cells. Okay. These are usually negative. They only come positive when we are thinking of follicular lymphoma. Okay. Yeah, so here they are actually negative, but the rest of all the cells are positive, mantle cell or whatever, if you think they are marginal zone cells, even T cells will be BCL2 positive. So this tumor is 20 and BCL2 positive. Oh, sorry, the BCL2 is there, so this is BCL2 positive. Now this is CD3. The upper two images are CD3 and lower two images are CD5. Again, I have put them side by side, so they are negative. Okay, this paler zone is negative. Only some cuffing around the atrial, which is positive, right? Which is an expected CD3 here, and some sprinkling of CD3 in the red pulp is there, and of course CD5 positive T cells also. So CD3 is negative, even CD5 is negative, right? What is happening here in CD10? Upper two images are CD10.
Negative.
Negative.
It looks negative, and you can see this very small atretic germinal center probably, which looks weakly positive here. Okay, so this CD10 is negative. What is happening to CD23?
Negative.
What is this highlighting? This is highlighting FDCs, right?
Relatively positive.
Follicular dendritic cell, but it looks like it is maybe weakly positive, right? It does look like weakly positive. If someone said positive, I think you are absolutely right. Then you do cyclin D1 because you want to rule out mantle cell lymphoma, correct? But CD5 mantle cell, can it happen? CD5 negative mantle cell?
Usually no, sir.
Yeah, usually no. Very good. But very rare cases can be CD5 negative. That's why if you have strong suspicion on histology, you still want to do cyclin D1 to rule out mantle, right? So this cyclin D1 is negative, okay, in these nodules, and also here intermittent. What are these cells which are positive in cyclin D1? Can you tell me? This actually acts as an internal control here. Can you see?
Macrophage.
Here, these cells. Can you see?
Macrophage.
These are actually endothelial cells, okay? Endothelial cells do mark with cyclin D1 and they act as an internal control. So if you do cyclin D1, if you want to make sure that whether it has worked or not, you go and look for endothelial cells. If they are positive, that means your stain has worked fine. Okay. Now this is an IgD. So what is it? IgD, is it positive or negative?
Negative, sir.
Yeah, it's positive. It's positive. Okay.
Yeah.
It's definitely positive. And even not only the nodules are positive, but here you can make out that even in the in between there are this red pulp, whatever spilling we thought of, those cells are also positive. What is happening to IgM?
IgM negative.
Yeah, IgM is negative. So only one or two these cells which are seen positive must be your plasma cells. Okay, so that is act as your internal control. But the cells of interest, that means tumor cells, are negative here. Okay, and see this. What is this? Ki67 means MIB1 proliferation index. So what is happening here? It looks quite peculiar actually. Can anybody tell me what is peculiarity?
Nuclear stain.
Yeah, so MIB1 does mark nuclei only. That's how we know that this nuclei are proliferating or the cells are proliferating. But what is the peculiarity about here? Something.
Low proliferative index.
It shows
Yeah, so-
positive atretic germinal center and very low in intrafollicular area. So
Yeah, very good. So germinal center is showing nice strong positive, right? And then the area of interest is showing very less. But what is important to note here, that this seems like there is a target-like thing, in MIB1 here. The center is this germinal center, and the cells of interest which are in the periphery of these nodules are showing this positivity for MIB1. So this is very characteristic of this lymphoma. If this kind of Ki67 expression is also called annular or target-like Ki67 expression. Okay. So this, what was immunoprofile? We saw that tumor is positive for IgD. I think BCL6 must have been done, and which I have not seen here. So 20 IgD is 23 weakly positive. Okay, it is negative for CD3, CD5, CD10. So CD5 and cyclin D1 together, negativity rules out mantle. Correct. CD10 rules out your follicular lymphoma. SOX11 is again another marker for mantle cell, which is negative here. Correct. So keeping in mind, I think this is wrong. This must be BCL2 positive. BCL2, yeah. So positive is BCL2, CD20 and IgD. So looking at everything, so there is only one diagnosis. It is splenic marginal zone lymphoma. Okay. So it is an indolent lymphoma actually, and most often it presents splenomegaly, and also involves the bone marrow and peripheral blood. Okay, in peripheral blood, what do you see in a splenic marginal lymphoma? I think Dr. Gujral sir is going to show you, but I just want to know from anybody what peculiar cell you see in peripheral blood of the splenic marginal zone lymphoma. Okay, it is a villous lymphocyte, and I think you are going to learn about it. So peripheral, so lymph node involvement is very uncommon in this lymphoma. And in spleen, as we see that it shows you this micronodular infiltration with marginal zone differentiation, which was those paler cells are called marginal zone differentiation. I have already elaborated you what is immunophenotype of this. These are usually IgD positives and even IgM positive, and they are negative for CD5, CD10, CD23. CD43 can be positive or negative and has to be cyclin D1 negative. The common genetic abnormality seen in this is deletion 7q. Okay. Most patients have very better prognosis, and sometimes there are other events which happen like hemolytic anemia or immune thrombocytopenia, and also can have presence of monoclonal component. Okay, so in such cases, this other events, if they occur, then there is a shorter survival in these patients. The first line of treatment is actually splenectomy, so that helps in partial remission of the disease. And but if it doesn't improve anything, then they can still use chemotherapy agent, sometimes single agent like rituximab, or sometimes they can add another agent as well. And some cases are actually associated with hepatitis C infection, and somehow prognosis in such cases are better than those which do not have hepatitis C infection. And as like any other low-grade B-cell lymphomas, these can also transform into high-grade B-cell lymphomas or high-grade lymphomas, and up to 10% of cases can transform. Okay. Now let us take this case. Who is going to take this case? I think this is my last case. We can go quickly. Okay.
this is case of 53-year-old female presented with anemia, no atypical cells in peripheral blood, bone marrow showing hypercellular, no MDS. I'm not really good in medical abbreviations on English, so.
So this is myelodysplastic syndrome. Okay, no MDS means myelodysplastic syndrome.
And
Most
that's
often when you don't find any causes for anemia, or thrombocytopenia, or pancytopenia, then they resort to bone marrow to rule out if you are dealing with any myelodysplastic syndrome. Okay.
Okay.
Yeah.
Got it. And CT scan showing moderate splenomegaly with diffusely increased metabolic activity, no lymph nodes seen. Okay, gross examination showing solid deep red cut surface, no nodularity seen.
So what we can, excellent. So what we can learn from this histology, that patient had anemia and they were not able to probably see what was the reason for it, and that's why they did bone marrow, and bone marrow just hypercellular without any abnormality probably they saw, and there were no spilling into the peripheral blood actually because there are no atypical cells there, and patient does have moderate splenomegaly, but there are no lymph nodes, which is a significant finding. That means it looks like it is something which is more, actually must be something which is primary to the spleen, and it is solid red pulp lesion. That much we can say because there are no nodularities which are seen across, and this is the scanner view. Madina, can you please
Yeah,
explain?
so section reveals the encapsulated splenic section with incomplete presence of red pulp along with white pulp, I guess. But
Yeah.
can I draw it? I don't really think this area is. Yeah. So this area is like showing some kind of normal architecture. Meanwhile, this area is not showing any white pulp. I think it's like completely effacement. There's complete effacement of normal architecture.
Yeah,
And
I think, yeah, you're right. I mean, it looks like, in fact, entire thing, if you see, you can't make out much about where the red pulp is ending, where the white pulp is starting. It looks like there is kind of effacement of the architecture as a whole.
okay.
Yeah.
But
Okay,
this area,
before, tell me.
but I think we can still appreciate on this area like there is some remnants of white.
Maybe there is some remnant, but these are not like what you expect in a normal spin, right? It
Yeah.
appears something is abnormal happening there. More of a red pulp disease or something, correct?
Yes.
Yeah. Before we move on something, I want to show you something. What are these things, these lines? Can anybody tell me?
I think it's because of the microphony.
Excellent. So this is an artifact. If your knife is not sharp, then you go these lines or scores you get because there are abrasions on the knife. So this is an artifact. Okay. Let us go to now. What is happening here on a low power?
Okay, there is the predominance of red pulp compared with the white pulp.
Excellent.
And,
Yes.
yeah, and it's showing like enlarged like blood channels here and there, and I think I could appreciate it better if we would go to higher magnification.
Yeah. Very good. So this is what you see in a low power, and now this is another little high power.
And I
What do
can
you
see this infiltrate even in a white pulp, even in the red pulp. There is
Yes.
like monomorphic mostly lymphoid cells in a red pulp.
Okay. Whether they are monomorphic or not, we'll go to one more high power and then check, right? But it looks like here at least one could quite sure now looking at the scanner view, low power and this intermediate power, that something we are dealing which is a red pulp disease, right? It's not a white pulp disease. That much I think we are clear. Now what is happening here? Little more higher power.
Okay.
Can you say it is now monomorphic or there is polymorphic?
Yeah, it's more looking like polymorphic now to me than monomorphic because some cells are showing intermediate size, and for me, some cells look more large in size compared to MBC, and even the sinuses are like filled with this lymphoid infiltrate. And
Very good. I agree with that. We'll go to one more high power. So here, I mean, cells, you rightly said some look intermediate, some maybe little larger cells, So it has some polymorphous thing. It is in the red part. This is much more higher. This is the large
yeah,
intermediate.
some cells are showing vesicular chromatin along with conspicuous nucleoli, and but most of them are hyperchromatic.
Yeah. So it is kind of mixture of intermediate to high large cells, right? And that too, it is happening in the red pulp. Okay. And maybe there are some, yes, right. There are some plasma cells are also there in between. Correct. So basically, it is different cell types are there. So what will be your differential here?
So it's lymphoproliferative disease. So
Okay.
my differentials would be splenic marginal zone lymphoma, hairy cell leukemia, maybe.
Okay.
What else it could be?
Lymphoplasmacytic lymphoma.
Okay, very good. Yeah. So something which is mainly affects the red pulp, right?
Yes.
So something like hairy cell leukemia or lymphoplasmacytic lymphoma will come into the picture first. Splenic marginal zone, yes, but we didn't see those, follicles or nodules which were seen in a previous case. Very rarely it will have such a very diffuse or wide thing. But yes, all these will be the differentials one would like to, rule out while doing the IHC. What is peculiar about it that, when we are seeing all these differentials, they are usually small cell lymphomas. Here, somehow the cell size is not that small. It looks more intermediate size. So anyways, we have to do IHC to rule out all these differentials. This is a CD20, which is nice and diffuse positive, right? CD3 is negative, only the reactive T cells are positive, okay? Similarly, CD5 is negative, only few reactive cells or reactive T cells are positive. CD10 is negative. CD23 is negative. Cyclin D1 again is negative. You can see some endothelial cells which are positive. So cyclin D1 is also negative. DBA44 is a marker you do for hairy cell leukemia usually. It can be positive in other small B cell lymphomas as well, but as a panel you do, which is also called hairy cell leukemia antigen, DBA44, but it is negative here. IgD, which is done, you get splenic marginal zone which are positive for IgD. It is negative, so IgD is negative. It is BCL2 positive. I told you BCL2 comes positive almost in all B cell lymphomas. So actually, its role in diagnosing B cell lymphoma is very limited, wherein you are trying to differentiate a reactive lymphoid follicle versus follicular lymphoma. There it is can be used. Seldom you can use as a marker wherein decreased expression of BCL-T can be taken as one soft pointer for diagnosis of T cell peripheral T cell lymphomas. But that's how you can use the BCL2. BCL6 looks positive here. Okay, it is a nuclear marker, and I think good number of cells are positive here, and at least more than 50% are positive. This is the kappa-ish, means inside to hybridization, which is done. We have seen the plasma cells there. So some plasma cells are taken, and also lambda is also, this is lambda, so lambda is also taken. It's not like only one type of plasma cells are there, either kappa or lambda. So these are like a mixture of both kappa and lambda. So it looks like these are not light chain restricted plasma cells. Okay, these are reactive plasma cells. They don't look, seems to be a neoplastic plasma cells. And Ki67 looks quite high, right? It's almost more than 70%. It's 75 to 70 to 75%. Okay. So what are the positive stains here? CD20, BCL2, and BCL6. Plasma cells are polytypic. Yeah. No, kappa lambda is polytypic. So these are, you cannot call it as a restriction. You cannot take it as a neoplastic plasma cells or cells showing restriction. Negative stains were CD3, CD5, CD10, 23. So you have ruled out mantle, you have ruled out follicular, you have ruled out hairy cell leukemia. DBA44, CD25 usually comes in positive, as well as annexin 1 is a very good marker for hairy cell leukemia. All three are negative, so it is unlikely to be a hairy cell. IgD, IgM negative, so if you're thinking of splenic marginal zone, which is also not there. So you are ruled out all this, whatever differentials we had thought of, you are ruled out. So I would say it is like a high grade red pulp B cell lymphoma because the MIB1 is quite high. Now there is one very special type of lymphoma which occurs in spleen, which is called a splenic diffuse red pulp small B cell lymphoma, which it doesn't qualify because the cell size looks intermediate to large. It has got very high index, so it is unlikely to be this kind of lymphoma. Okay, so this we will take it here as a high grade red pulp B cell lymphoma. Okay, and could it be transformation from something low grade which are there and now it has become high grade? It might be possibility, but here we won't be able to prove it. Okay, so if you have to say which lymphomas involve which compartment of the spleen, then if white pulp is predominantly involved, then you have to think of splenic marginal zone lymphoma, follicular lymphoma, mantle cell lymphoma, SLL, CLL, and DLBCL. Okay. Now the SMZL, that is splenic marginal zone lymphoma, and CLL, SLL can also show you red pulp involvement. So you have to remember like that. If something which has got white pulp involvement as well as red pulp involvement, then think of SMZL or CLL, SLL. Okay, purely white pulp involvement is seen in follicular and mantle cell. Rarely you can have even red pulp involvement in mantle cell as well. Now, if you have only red pulp involvement, that is seen in hairy cell leukemia, splenic diffuse red pulp small B cell lymphoma, lymphoplasmacytic lymphoma. If it is a T cell lymphoma, then hepatosplenic T cell lymphoma, and CML can also show you red pulp involvement. You have seen one of the cases today. Okay, so these are the differential of actually what splenic B cell lymphomas can occur in spleen. We only concentrate the first four actually, which are seen only in spleen. So what they look like in spleen, in bone marrow, and what are their IC profile. If you take splenic marginal lymphoma, I have already told you it is a nodular lymphoma having prominent marginal zone and can involve red pulp. In bone marrow, it has intrasinusoidal or interstitial nodular pattern. And the immunoprofile I have already mentioned, so I am not going to detail. The red pulp disease, which is small B cell, is a splenic diffuse red pulp small B cell lymphoma. It shows you very diffuse red pulp involvement. It shows involvement of the cords and sinusoids. It will show you blood lakes also. And typically in bone marrow, you see intrasinusoidal pattern mainly, but also can have nodular interstitial pattern. And this lymphoma, apart from CD20 positivity, can show you some DBA44 positivity, but it is annexin 1 negative, CD25 negative, and CD123 negative. As opposed to that, hairy cell leukemia is also a red pulp disease. You will have diffuse red pulp involvement of the cords. There will be effacement of the white pulp, and you will also get to see blood lakes there. In bone marrow, if you see the hairy cell leukemia infiltrate, it will be dense, diffuse infiltrate, and there will be fibrosis. If you do the reticulin, you will see nice fibrosis in the hairy cell leukemia. Hairy cell leukemia has very specific marker is annexin 1. It comes annexin 1 positive. If you don't have that marker, then you can do DBA44, CD25, CD123. All these markers are positive. Interestingly, it is also positive for cyclin D1. But it is not a translocation which you see in mantle cell lymphoma, which is translocation 11-14. It is not related to translocation. It could be because of overamplification. So that's why cyclin D1 comes positive. But this is usually big cyclin D1 positive, and this can be even CD43 negative. Now coming to lymphoplasmacytic lymphoma or Waldenstrom macroglobulinemia, in spleen they can also show you red pulp involvement with marked plasmacytic differentiation. So you will have something like a small lymphocyte, as well as there will be plasma cells or cells which are both characteristics, lymphocytes and plasma cell characteristics. And in bone marrow, it usually shows you diffuse involvement. What is there that apart from CD20 positivity, it will show you IgM positivity on immunohistochemistry, and you will be able to show light chain restriction in the plasma cells. That's how you can differentiate from other differentials which are happening in splenic small B cell lymphomas. Rest of the differentials like CLL, mantle, and follicular, I have already mentioned how you differentiate on IHC. The peculiarity about the follicular lymphoma in bone marrow involvement is a paratrabecular involvement. They are almost always like a paratrabecular, and if you see that kind of positivity in bone marrow, then you can certainly say that it is involved by follicular, or at least make them aware if they are not aware that there are lymphadenopathy. You can ask them to do lymph node biopsy. Now this is my last slide. There are things which have changed from last WHO to recent WHO, which is WHO 5. So there are something which have been removed, like this lymphocytic B pro lymphocytic leukemia has been completely removed. The new entity which has been added here, which is the splenic B-cell lymphoma leukemia with prominent nucleoli. I think Dr. Gujral is going to tell about it. Okay, and here is a leukemia variant which used to be there previously. Now they are no more called varicose leukemia variant, because many of these cases have something which is now called splenic B-cell lymphoma leukemia with prominent nucleoli. Usual hair cell leukemia remains the same. Splenic marginal zone lymphoma remains the same, except that some of the splenic marginal zone lymphoma now are reclassified as splenic B-cell lymphoma leukemia with prominent nucleoli. And pro B lymphocytic leukemia, which was an entity, now they know that some of the cases are actually mantle cell lymphoma. Some of the cases actually fit into this new entity of splenic B-cell lymphoma with prominent nucleoli. And if there are actually cases which are actually pro lymphocytic progression of a usual CLL, and now that you can say pro lymphocytic progression of CLL only when if you have more than 15% of pro lymphocytes. Okay, anything below that you will just say that this is CLL or SLL. Okay, so with this I will stop here, and if I will ask any comment or anything if Dr. Gujral would like to show you cases. Gujral sir.
I do not know if the students still have energy to. I will quickly go through, I think, my slides to complete the basically spleen session. Is it okay, students? I'll take maybe not more than 10 minutes.
Sure,
I
sir.
will show you the role of.
No, Sumit, you must take this because it's important, you know. The hairy cell part of it is important.
So we finished almost 9:45 now. So it's a kind of a symposium on spleen today. So wonderful, great cases, Praveen. I mean, this has been shown to you. This is a classical margin zone lymphoma picture. I just thought I had a good, nice picture, so I thought I'd share with you. Nice nodular patterns. And if you look at peripheral smear of these lymphomas, we call them CLPDs, chronic lymphoproliferative disorders. Low-grade lymphomas, and the commonest one is CLL. And then there are other ones which Praveen told you: splenic margin zone, hairy cell, follicular, margin zone, Waldenstrom's. They are the mantle cells. These are the less common ones. So there are 4 cases in this picture. This is SLL, this is SLL, this is also SLL. Maybe one of these is prolymphocyte, and this is a mantle cell lymphoma blastic. So morphology, you can go wrong. You can't be sure, and this could be marginal zone also. Though the cells have scanty cytoplasm, it has a notch, and these cells also has you can see the clefts here. So here also there's a cleft here. So generally we read that cleaved cells are follicular or mantle, but you can see them in CLL also. So what we do, we basically need more markers like IHCs or flow cytometry. Similarly in Trifine, if you look at, there are different patterns which Praveen just now told you. This is like a diffuse pattern. The whole bone marrow is replaced by a tumor. There's no fat cells. Now this marrow shows you a pattern which can be called as diffuse but interstitial, because you can see nice fat spaces. So you have an architecture which is kind of a maintained, but the cells, and you can see megakaryocytes also many, but there's a sprinkling of lymphocytes here, sprinkling diffuse. Now this case shows you nodular aggregates which are intertrabecular. Now this is a bone. So anything which is close to bone, which will be paratrabecular, this is intertrabecular. This is intertrabecular lymphoid aggregate. This is also intertrabecular lymphoid aggregate. Now this is called as paratrabecular lymphoid aggregate. Here also. This is classically seen in follicular, sometimes in mantle cell lymphomas also. And now this is kind of a nodular aggregates. This is a tumor and this is a normal marrow. So this comes in many lymphomas. It can come in Hodgkin's, DLBL, myelomas. So this kind of nodular aggregates. So that's how, if you do aspirate from here, you might report it as a normal marrow. And if you do aspirate from this nodule, you might call it 100% tumor cells. So that's why the aspirate and biopsies are complementary. So these are the common patterns: packed, diffuse pattern, diffuse interstitial pattern, intertrabecular, nodular, paratrabecular, kissing the bone, and nodular aggregates. So if you do CD20, let's say this is a case of maybe a margin zone lymphoma, which shows you nodular aggregates. This is a case of, again, this is a bone. This is a bone, and the tumor cells are all CD20 beautifully positive. This is classical paratrabecular, like going like a snake, like a river. Follicular lymphomas, they come like this. Now this is a very difficult but subtle infiltration intrasinusoidal of B cells, which can be seen in marginal zone. So this can be also seen in splenic marginal zone. This pattern can also be seen in splenic marginal zone. Now, why I'm sure of this case? Because we could prove the clonality by flow. Otherwise, it's tricky to pick up the scanty intrasinusoidal cells. But this is the pattern of intrasinusoidal cells, sinusoidal cells. Now, this is a diffuse interstitial increase like hairy cell leukemias, like normal marrow and sprinkling of lymphoid cells. Now, I'll show you some cases on flow, because flow is very important in diagnosing this, subtyping these lymphomas, because these days nobody does splenectomies. You don't get splenectomies. Very rarely you get splenectomies now. You get, generally these cases come to peripheral blood or the bone marrow and you do flow. So in the flow, because these present cases patients will they're generally elderly, they present with lymphocytosis. They may be asymptomatic, but mostly they are low grade, asymptomatic, accidentally detect to have high counts. Very high counts, even normal white cell count, but with the relative lymphocytosis. That's the lymphocytes 50%. We have a case of carcinoma bladder, which come to Tata Hospital for the treatment of carcinoma bladder. But when we do routine CBC, the lymphocytes were 52%. Total count was 6,200. So the absolute lymphocyte count was a little high. So we did the flow and we picked up a small B cell clonal population, which was CLL phenotype. We call them MBL, monoclonal B lymphocytosis. So now here, if you see, you have to rule out the benign. You basically by clonality, you can do clonality kappa lambda by flow. And now once you are sure it's a lymphoma, then you have to say it's a B cell, it's a T cell, or it is a NK cell. So there are 3 types of common, and plasma cell myeloma also, the Waldenstrom's or the plasma cell could be the 4th type. So they are B cell phenotype only. Then you could also mention about the prognostic markers by flow, in CLL, CD49D, and ZAB. Now this is the picture to show you what Praveen has told you. There are different types of CLPDs. The commonest one is this. In our practice, in our hospital, 65% of all CLPDs are CLL. So if you have a CLPD, you think of CLL, CLL, and CLL, until proved otherwise. Because CLL have a normal white hemoglobin, generally normal platelets. They generally come with high counts. Hairy cell leukemia classically comes with pancytopenia. The healthy, the patient may be looking very healthy, well preserved, but they have pancytopenia. They have big spleen. They are generally 40 years, 50 years old. Now mantle cell follicular, they also could be well preserved. Burkitt lymphoma, we know it's a very high grade lymphoma. It doesn't come into the differential. It's a high grade. It's a classical morphology, and there's a diagnostic criteria. Now, lymphoplasmacytic lymphoma or Waldenstrom's can come in differential of marginal zone lymphoma. We'll see that. And then obviously this new entity, splenic lymphoma with prominent nuclei. Splenic B cell lymphoma. This is basically includes 2 major entities. One was hairy cell leukemia variant, which is not existent anymore. And second is all cases of B cell PLL. So there is nothing called as de novo PLL. PLL has to have a history of CLL to call it PLL transformation. Otherwise, de novo PLL is not there. So all those cases of hairy cell leukemia variant and B cell PLL, because both of them have a prominent nuclei. They look like CLPDs and they have a prominent nuclei. And we used to put into these 2, I'll say waste baskets, because we didn't have a label. So now the WHO still doesn't know what is it. So, but to simplify, they made an entity where you can put these both categories. Now, basically flow. If you get a case of leukemia, what do? You have some initial gatings. You basically remove the doublets. Then you do forward scatter, which is for size. Side scatter is for granularity. And based on that, these are lymphocytes. These are neutrophils. Monocytes will be here. Now let's take our case, one case, just to show you. This is a case of CLL, suspected CLL, CLPD. This is a forward scatter, side scatter. We know that many cells are here. These are monocytes, these are neutrophils. Now, these blue color, if in this gate, when you do CD45. Now, CD45 is leukocyte common antigen, HCl. So this is also, you can call it lymphocyte common antigen because it's strongest in lymphocytes. It's very strong. And they don't have granules. These are monocytes, they're also pretty strong. Neutrophils show a variable positivity. The mature neutrophils are strong or moderate, and the immature neutrophils, which are myelocytes, promyelocytes, are weak. So this is a bone marrow now. This is the way it shows you the pattern. Now, if you do CD5, on the x-axis we've done, 19 is a B cell marker. This is B and this is a T cell marker. You find 4 plots here, 4 dense populations. Now, this population is
CD5
positive for both B and T, 19 and 5. This is only
19%.
Only B cells. These are pure T cells. And these are
Negative.
monocytes or something else. So these are your B cells. These are your T cells, possibly. These are your other cells. And these are your cells which are both B as well as T. So these are your possibly neoplastic. Because CD5 can be expressed in B cells to a smaller extent. Few 2%, 3% B cells in peripheral blood can express CD5. But this is a big population. So if you look here, and this population is both positive for CD20 also and 19. So we know there's a B cell population which is very significant and it is expressing 5. So I have 2 differentials for a postgraduate, CLL and mantle. Because B cells expressing CD5 and they were negative for 3. Okay, so just to make a table, now this is an algorithm, just to simplify for you students. Let's take CD19 positive CLPDs. I'm not talking about T cell lymphomas, I'll talk only about B cell lymphomas and their algorithm. So CD45 is strong because CD45 is only negative or dim in blastic leukemias. Okay, so then next 10 years important strain is 5. If 5 is positive, you do CD200 or CD23. These 2 markers are important. If both are positive or one is positive and it is dim 20, it is classical CLL. But if it is strong 20, it becomes atypical CLL. This is rare. This is common. Then you do, if these are markers, these are 2 markers, both negative, then you are possibly dealing with mantle cell lymphoma. And mantle cell lymphomas are 20 strong. And they show you nice light chain restriction. Kappa lambda restriction in CLL is very weak. CD20 is weak. So you should know that sometimes in your lymph node biopsy, if CD20 is negative, it could be, your staining is bad. Maybe it is weak positive. It still could be CLL. So CD20 negative, if it is, you have to be sure about your quality control of how do you do CD20. Many times it is weakly positive always. But sometimes if it is negative, do not rule out CLL. You have to look at the quality and maybe do PAX5 or 79 alpha. Then rarely 5% of other B cell lymphomas can also express 5. Like marginal zone can express, hairy cell can rarely express. So CD5 doesn't mean that it can't be seen in other lymphomas. Now we go to another situation where 5 is negative. Here we look at now next magic marker is 10. So after B cell 19, the first magic marker is 5 and the second magic marker is 10. If 10 is positive, we basically working with follicular or DLBL. I won't go into the details. DLBL based on large size because large size will have high forward scatter. And similarly, if 10 is positive and these markers, 38 very strong, 81 very strong, and morphology is like vacuoles, in the nucleus cytoplasm, blue cytoplasm, you are dealing with Burkitt's. Now, Burkitt's is a classical morphology, but you have to remember Burkitt's are also CD10 positive. They are BCL2 negative, and the MIB one is 100%. Now, 10 negative cases are basically divided again into DLBCLs, or they could be DLBCLs ACB type activated. Now, let's see, your both magic markers are negative. Now you're dealing with today's topic, the other three splenic lymphomas. So here you do these classical markers for hairy cell leukemia. There are actually many more, but these are the 3, 4, 5, 11C, 25, 103, 123 is not mentioned here, annexin, CD305. So if these all are positive and CD5, 25 is strongly positive, we call it hairy cell leukemia. Now, if CD25 was negative, it used to be called as hairy cell leukemia variant. So I think I should not mention it here. I will leave it here because this is an entity. I will talk about it maybe in my next few slides. So if both are negative and 11C is weak or negative or dim, and 25 is also dim, you are possibly dealing with splenic margin zone lymphomas, or Waldenstrom's. In the splenic margin zone lymphomas, very interesting marker is CD180. So this is a good marker which we use in our practice, and 180 is almost always expressed strongly in, moderate to strongly in margin zone lymphomas. And Waldenstrom's, obviously, you need MYD 88 mutations. You need to do molecular, apart from IgM on serum electrophoresis or on the IHC. So I'll just show you. These are the two cases of CLPD, like classical CLL. And now this was the case which was called as PLL many months back. Now we can't call it PLL as plus WHO. We need to call it splenic B-cell lymphoma with prominent nuclei. B-cell after doing 4 IHCs. It should be 20 positive or 19 positive. 54-year-old male has pancytopenia, has spleen. So, history is very important. Now, pancytopenia and big spleen, it won't be aplastic anemia. Can't be, spleen won't be there.
Mostly hairy cell.
Hairy cell. The history tells you that it's possibly hairy cell. So you look at hemoglobin is low here, white cell is low, platelets are low. Here the lymphocytes are only 22 though. They're not many. Even on differential manual, they're not many. But you do the bone marrow, there are these cells, which look like fuzzy cytoplasm. The cytoplasm is almost disappearing into the slide. There's no it's not like this is more like erythroid cells. They have nice, margins on the cytoplasm, but this is like fuzzy. These are all hairy cells. They look like slightly plasmacytoid here. These are all hairy cells. These are erythroid cells. You could do the markers, as I mentioned, CD45, then you do 20 and 19. So we select our B cells. These are our B cells. Now we'll study these B cells and we see whether they are 5 positive or 10 positive. If they're negative for 5 and 10, then we work up for they are 5 negative. Kappa and 10 also negative. These are some 10 positive cells. They could be neutrophils also. CD10 can also come positive in neutrophils. So the internal control for CD10 is neutrophils and fibroblasts if you're doing histopathology. And if you look at the light chain restriction, kappa is nicely positive. There's no lambda, very few. There are very few plasma cells may be lambda normal. The tumor is kappa light chain restriction, restriction. So this tells you it is a clonal population of B cells. Here also we knew that it is clonal. There's so many plasma cells, but this is proving it because normally in peripheral blood we have 5% or 10% B cells, maximum 15 to 20%. In your and my peripheral blood, 70% are T cells. If you take your blood and take lymphocytes, 60%, 70% would be T lymphocytes. B cells are 15%, max 20%. So here the B cells are many, and they're all showing light chain restriction also. Yeah, we did 11C, 200. This is also a beautiful marker for hairy cell. We generally use it for CLL because it is negative in mantle cell lymphoma. So CD200 comes positive in all lymphomas except mantle cell lymphoma. But in hairy cell leukemias, it comes classically positive. 25 positive, 103 positive. These all are markers for hairy cell. Also hairy cell. 123, 305. So all markers for. So what's the diagnosis? Hairy cell leukemia. I'm sorry, I'm not asking you questions because I'll carry on, okay? So I'll show you some pictures of hairy cell leukemia, which are beautiful ones, but you won't get such beautiful pictures in hairy cell leukemias. 50, 60, 70% of cases of hairy cell leukemia, you won't get this kind of cytoplasm. You won't get this kind of abundant, fudgy kind of cytoplasm, bluish gray. You might, but the nuclear content is very bland, homogeneous. Look at this, very bland, something like monocytic. So you have to not diagnose hairy cell leukemia based on cytoplasm, not based on the hairy projections, because you might not get hairy projections. Something like in APML, you don't get faggot bodies in all APMLs. The phago, you see multiple or rods. You don't get in all APMLs. But you still diagnose APML based on the morphology of tumor cells. Phagos is seen in 10, 15, 20% of APMLs. Similarly, hairy projections will be seen in maybe 20, 30% of hairy cells, not in all. So you have to be careful on the history, clinical. If you have a morphological doubt, please do bone marrow and do flow. These are different hairy cell leukemias. All these are hairy cell leukemias. The Trifine, as I told you, diffuse interstitial, fried egg appearance. The cells have fine fibrosis. Means this is a high power picture of hairy cell leukemia. The different pictures of hairy cell leukemias, different cases. So classically, hairy cell leukemia, I think 5-6 points. Age is 30 to 50 years old. Pancytopenia with spleen. Perfus smear shows pancytopenia, classical morphology. Trifine, I told you, fried egg appearance, convoluted nucleus, and flow cytometry, all so many markers. And now the molecular marker is a must now because hairy cell leukemia have a definite therapy. You give purine analogs, sclerabine, sometimes rituximab, and they have very good prognosis, excellent prognosis, hairy cell leukemias. So you need to diagnose hairy cell leukemias. So spleen, Praveen has shown you, there are sections from spleen showing you hairy cell leukemias. I go to next case, a 44-year-old male who came to us, weight loss 5 kilograms, has lymph nodes. CBC is normal. So 44 male lymph nodes. And we saw in the bone marrow, we saw some cells like these two. This one. They look like lymphoid. No, they could be normal, but there are 5 in this field. In this field, there's only 1. So a good differential by pathology students is very important. So now if you look at this, if you miss it, okay, you might think of 10%. But if you think the lymphoid cells are going more than 20%, 25%, you have to be careful. Generally, in adults, the lymphoid cells in bone marrows are 10%, 15%. They don't generally cross 20%. So if you have it in the context of history, if you have slightly more lymphoid cells, the patient has lymph nodes, you do flow. And in the flow, 45 strong, and there are B cells, 19 and 20 positive, 10 negative, 5 negative. LTC weak. It's a weak population. Very small, mostly negative. 23 positive. Now 23 is not only in CLL. It can come in many other lymphomas. It doesn't come in mantle cell. 25, very weak positive. 103 negative. Kappa restriction is very nice. This is not CLL. 20 was strong, not CLL. Now 148 is negative. 148 comes classically in mantle cell lymphomas. And 180 is beautifully positive. As I told you, it comes positive in splenic margin zone lymphomas. So this is your negative control here. This is negative, and these are all positive. So this is 180 positive. So we are going towards splenic margin zone lymphomas. And then you do other markers. BCL2 is positive. These are the normal other cells which are negative. Normal B cells negative. Now you do MIB1, which is very, it is very low MIB1 here. This is a MIB1 in the other cells also low, but in the tumor cells it's low. So it's a low-grade B cell lymphoma, and it was a case of margin zone lymphoma. We didn't have spleen in this case, so we didn't call it splenic margin zone lymphoma. We call it margin zone, but the immunophenotype is more or less same. Splenic margin zone lymphomas though express nicely IgD. But here also in margin zone nodal also you can get, IgD and IgM. IgM classically seen in Burkitt's, classically seen in CLL. And Waldenstrom's. These 3 lymphomas classically see IgM. Next case is 54-year-old male, asymptomatic, peripheral blood shows leukocytosis, and they are mostly lymphoid cells and big spleen. So again, splenic lymphoma, maybe CLL, but this morphology is classical of splenic margin zone lymphomas. CLL, I don't think I put many slides of CLL. CLL has a classical picture of, soccer ball chromatin. Soccer ball means it looks like football, like this. Chromatin is like, you have the euchromatin and heterochromatin making a kind of balls of blue balls with some white circles around them. But this is a nice, moderately abundant cytoplasm, fine chromatin, possibly a margin zone, and you have spleen. If you're lucky, you can get these nodular patterns. My last slide is a case of big spleen came to us, a young adult, 15-year-old, 18-year-old boy, and we reported it normal on the bone marrow biopsy, but on the aspirate, it was called as leukemia. Now, on the bone marrow biopsy, we realized there are some cells like these 5, 6 cells here, which were highlighted by CD3, and this pattern is called as? This is intrasinusoidal. So I've shown you already splenic margin zone lymphomas. It was CD20. Now this is CD3. So you can miss out these subtle infiltrates, which could be more actually, but you need to do 3 and 20 to pick up these kind of cytopenia, had blast-like cells in aspirate morphology, like here. But Trefine, we reported it normal. So we went back, we did 3, and this is a classical picture of hepatosplenic gamma delta T cell lymphoma. Hepatosplenic gamma delta T cell lymphoma. This is intrasinusoidal T cell lymphoma spread. So I think I've shown you, flow can help you differentiate all CLL, mantle, margin zone lymphomas. I think I'll stop here. If you have any energy left for any questions, Anita is here.
Yes, I'll be here forever.
And Parveen is there to answer the rest of the questions when Anita gets tired. There are still 80 students. I'm amazed that how come you splenomaniacs, whatever you call them, you still sitting.
Yeah, we are all 3 of us are here. Yeah. Anyway, are there any questions that the 5 of you have, or if there is are there any questions in the chat box?
But I'm extremely happy, Anita. I think I was not expecting this to be. It became a lymphoma symposium itself. Big thing in 3 hours in spleen.
No, but I thought it was a good collection of things that were benign, non-neoplastic, as well as neoplastic cells. So I think we took them through a panoply, as well as something about the normal histology and physiology of the spleen, because otherwise nobody, I think, even touches on these subjects. So if there are no questions, then I must say that I appreciated the interaction between the students. They all answered questions. I really enjoyed it. I hope that they enjoyed it as well. Yeah, Arun and Ravi and
Madina.
Yes. And, but I think we lost. Sorry. No. I think we lost Shambhavi. Is she there?
No, ma'am, I'm here.
Oh, you're there. Okay, because I thought you had dropped out, Shambhavi. And of course, there was Israel. So I hope all of you enjoyed it. And if you have any questions, you can ask them now, or just send it to our emails. Energy, and you think that you want to ask something.
Ma'am, there is one question, like which we diagnose one case as DLBCL. Sir, like if that's not the case, like if not going towards a lymphomas, can that be like a metastatic lesion to the spleen? Because some cells are looking.
So what metastasis you're thinking? Metastasis of which ward, like epithelial malignancy?
Yes, sir. Some more like an epithelial or a melanoma.
So epithelial, or even for that matter melanoma, usually you see a nice packaging of the cells. I like to call them packaging, like some nice nest or some differentiation, wherein they quite package. Wherein in lymphoma, although this case showed a sclerosis, if you see the cells, you quite make out that there is some discohesion between the cells. Okay. Other good clue of any lymphoid thing is if it is high grade, then you get to see apoptosis, individual cell apoptosis body, which are also one clue if you're dealing with something hematolymphoid or lymphoid. So I wouldn't think of epithelial or other malignancy in this case.
Okay, sir. Thank you, sir.
But yes, there will be some circumstances. You will have to think of your differentials will be between definitely hematolymphoid and epithelial in some cases, especially when you're dealing with small biopsies.
Okay, sir. Thank you so much.
Now that you brought up the subject, Arun, can you think, which of the lymphomas can be mistaken for melanoma or carcinoma?
Anaplastic large cell lymphoma.
Correct. And so those, and do you know why? Do you know why anaplastic large cell lymphoma can be mistaken for carcinoma or melanoma?
Mostly because of the chromatin.
No, it's not to do with the chromatin. No, it's about, you use the word epithelioid. They look very epithelioid because they stick together. That's what Praveen was saying. And this is all about adhesion molecules.
Okay.
When you have, for instance, ALCL expresses CD30, and when you get CD30 expression, you get this kind of sticking together. Okay, think about it. Which other cells express CD30? Embryonal carcinoma, nasopharyngeal carcinoma, they express CD30. And in fact, nasopharyngeal carcinoma actually gives you a sort of syncytial type of appearance because they're sticking so close together that you can hardly see the cell membranes. Okay, so everything has a reason.
Okay.
Yeah. Now, I don't know. I think Sumit has gone off to have his coffee, but I have never been able to find out, and I don't know if anybody knows what the cell of origin of hairy cell leukemia is, and why is it that it is in the spleen?
Actually,
I know about splenic. Are you there, Sumit?
Sir has left, ma'am. Sir
I know he's left because that's always bothered me, and I was hoping nobody would ask us that question because I don't know what the cell of the non-neoplastic cell.
It's actually given that it was given in one book that it is arising from like a plasma cell. It's arising from the plasma cell, like
arising from a plasma cell. That's a bit odd, right? It can't be arising from a plasma cell. I know that they talk about hemopoietic stem cells, etc. But why, if it is arising from a hemopoietic stem cell, and does it really involve the spleen? That has always bothered me. I don't know the answer to that question. So I am admitting to my ignorance. And if anybody can let me know, it's always bothered me why this the hairy cell leukemia, where we see no normal counterpart that is present in the spleen, and yet we see hairy cell leukemia in the spleen. So if anybody knows the answer or has found the answer or can find it out, I would be very happy to get an email to tell me why you get what is the normal or counterpart of hairy cell leukemia, and why does it occur in the spleen? Okay, but it does occur in the spleen. We don't see any spleens. I haven't seen a spleen, with the hairy cell leukemia now, I think for decades. At one time, they used to remove the spleen for hairy cell leukemia, but I haven't seen one because now we make the diagnosis on the marrow, which is so, and we've got very effective drugs for hairy cell leukemia. People used to die. You don't even remember. You're so young that you don't remember that people used to die of hairy cell leukemia. Now they don't, which is an amazing advance. Gastrointestinal stromal tumors, they would die. Today they don't. So CML, we have people living for 15 and 20 years with CML, which was an impossibility once upon a time. Okay, so I think that we're doing well as far as some cancers are concerned, but we have a long way to go. So I do hope that you enjoyed the session on the spleen. Okay.
Yes,
if you have learned something at all, I think you should take away the message that the spleen should not be, sort of considered like a large lymph node. It has its own histology. It has its own functions, and the spleen is an organ that we still are finding out so much about. We don't know. And hairy cell leukemia is still one of those things that remain a mystery. Okay, so Madina and Arun and Ravi and Shambhavi, and I don't know if Israel is still there. For us, it's late at night. It must be for you as well, right? Because you told me, Mandya, that we are on the same latitude. Yeah, what's the time over there in Tashkent?
21:42.
What's the time in Tashkent?
It's 21:42, 9:42.
9:42.